Good morning, good morning. Good? Yes, okay.
Good morning, everybody. If we could please have you take your seats, we are about to begin in just a moment. If you could please take your seats, thank you.
Good morning. Well, that sounds great. Good morning. Good morning. We're about to start. I think we have a full house today. This is amazing. How's everyone doing this morning? Good? You guys had your coffee, had some fruits, croissants. Well, I am so excited to be here another year. We're happy to have you here and welcome. Welcome everyone to the Brain Impact Summit Spotlight on Parkinson's Disease 2026. My name is Giselle Tejeda. I see a lot of familiar faces. I'm a news anchor at Telemundo Orlando, and it is truly an honor to be here. I take so much pride in being a part of this event, being able to connect with you all. This event, as we all know, is presented by Neurology One in partnership with the Parkinson Association of Central Florida and made possible to the support of our sponsors, including our presenting sponsor, GE Healthcare. Today, my friends, we come together with one shared purpose: to learn, to connect, and most importantly, to remind each other that no one is alone in this journey. For me, this summit is deeply personal. In the past, I've shared with you all my experience with Alzheimer's disease, watching my grandmother go through it, and ultimately losing my grandmother to the disease. It shaped the way I understand brain health and the importance of having a community. But this year, this summit hits differently, and it hits closer to home. My own father has recently become a caregiver to his younger brother who's living with Parkinson's disease and is now under the care of Dr. Lourdes Benes. It's been very difficult to watch him step into this role, and it has definitely given me a whole new perspective on what it means to be a caregiver. The quiet strength it takes, the patience, the love, and sometimes the uncertainty. Like so many of you in this room, we're learning in real time what it means to navigate this journey as a family, and how important it is to have support, guidance, and community. So today, I am not just here as your host. I'm here as a daughter, as someone who has seen this journey from both sides, and as someone who truly understands how much days like today matter. And now, it is my honor to introduce someone whose leadership and personal story reflect the heart of this community. Sarah Brady is the president of the Parkinson Association of Central Florida. She began her career as a reporter with the Orlando Sentinel, covering police and court beats. After 15 years in journalism, she transitioned into public relations before funding her own firm, specializing in crisis management and strategic communications. Her connection to this community, my friends, is deeply personal. In 2021, she lost her husband of 24 years, Barry Brady, after a long and courageous battle with progressive supranuclear palsy and a typical form of Parkinson's disease. Since then, she has become a powerful advocate for patients and families navigating this journey. Please join me in welcoming Sarah Brady.
Good morning. I have my glasses on. I just want to take a look at you because I can see you with these, but I got to take them off because I don't wear reading glasses and I have to read my notes. So you all look lovely. I want to say I'm so happy being here today representing the Parkinson Association of Central Florida and to help get today's program started. This is my second year attending the Brain Impact Summit. I'm glad to be back because I know this is a day filled with important information, camaraderie, optimism, care, and hope. And who doesn't want a dose of all of that? On behalf of the PACF Board of Directors, I'd like to say a heartfelt thank you to Neurology One for creating this event, and more importantly, for what continues to be an outstanding and thriving partnership between us and our shared goals of supporting the PD community. I have never seen a more authentically engaged and beloved physician group than Neurology One. I say that for real. I came to PACF not just from the Parkinson's disease perspective, but also as a caregiver in need of support. My husband, Barry Brady, was diagnosed in 2018 with progressive supranuclear palsy, an atypical form of Parkinson's. His diagnosis came after about 2 years of us not knowing what was wrong with him. And let me just say, Brady got really tired of hearing me say, "What the hell is wrong with you?" Then we got the answer. Like most caregivers, my new role was unanticipated, and it was dramatic. I spent a few years feeling overwhelmed and exhausted. Fun fact, as we moved forward through this process, it was Dr. Benes who confirmed my husband's diagnosis. She also is the one who told him to listen to his wife and do what she tells you. I will never forget that small act that meant so much to me, and he actually did listen to me. PD is such a challenge in so many ways, and those who have no connection to it can't really understand the depth of the physical and emotional demands that Parkinson's patients and their caregivers endure. When Brady was diagnosed, he had already been retired from his law enforcement career, and I was still running my crisis management firm. Unexpectedly, I now had my own crisis. But at the time, I was not aware of PACF, so I know what it is to feel alone and scared. Now I also know what it feels like to have a tribe. PACF was founded and is operated by people who know firsthand what Parkinson's is. Our board is made up of people with PD, caregivers, and advocates from the Parkinson's community. Because of our collective knowledge and experiences, PACF focuses on things that matter, providing resources, education, and support that enhance the quality of life for all of those affected by Parkinson's disease. Our relationship with Neurology One is a shining example of that. Our website should be your go-to destination to find resources related to physical, occupational, and speech therapy services, counseling, our grants programs, respite for caregivers, arts and exercise programs, and support groups aplenty. We have a bodacious calendar of relevant events. There's pretty much something for everyone. And if you can't find it on our website, you can always call us. Which leads me to my final point. Next Saturday, April 4th, is our annual Walk for Parkinson's, which will take place at Crane's Roost in Altamont Springs. This walk is one of our big fundraisers, and it's what enables us to continue to provide grant monies and support for so many invaluable services for the Parkinson's community. That's all of us. And this is important. What makes us different from other groups dedicated to Parkinson's support is that the monies we raise stay here in this community. Your dollars stay local. We support this community. We support you. The walk, it's a thing. It's evolved into the largest gathering of the PD community in the state of Florida. And in my opinion, that's because we come together for a few hours as a mighty and optimistic tribe of warriors. This event is a positive and uplifting experience, and the walk is just a mile. It's just not that far. And this year, our event falls on Easter weekend. It's the perfect time for friends and loved ones to come together as a very large and dynamic family. I encourage you to come join us at the walk. You can find information about it at our table outside, which is either that way or that way. I'm a little confused. You can go to our website, you can click on the walk icon, and you can start a team, you can join a team, you can join my team, which is Brady's deputies, but either way, come and feel the power of your people. Dealing with Parkinson's is our fight. We are all in it together. Look around this room. Clearly, you are not alone. So thank you for your attention. Thank you again, Neurology One, for defining the word amazing and defining the way healthcare should be delivered. And to everyone here, embrace all the goodness to come from this day. Thank you.
Thank you, Sarah, for sharing your story. And I think thanks to organizations, right, like those, we need to take advantage of them and participate and be able to raise funds so we can shed more light on this disease. If you're living with Parkinson, I want you to please raise your hand. If you're a caregiver, please raise your hand. If you're here supporting someone that is going through the disease, someone that you love and care for, please raise your hand. Take a moment, keep those hands up for me, and just take a moment to look around. This is, my friends, what strength looks like. This is what resilience looks like. This is what love in action looks like. And today, this event is for you. It's for you. And to our caregivers, we see you. We appreciate you. Throughout the day, we have a recharge lounge available to you. I'm so excited about this. It's the first time we're doing it. It's a quiet space where you can go, relax, sign up for a short seated massage, and take a moment to breathe. Sometimes we just need to breathe. So if you can, visit that recharge lounge. It's there for you. Take advantage of it. We encourage you as well throughout the day to visit our resource village. I know a lot of you guys were out there getting information. You will have time to do so. Our partners are here not just as sponsors, but as resources for you and your families. As well as on your tables, you guys should have some note cards. I want you to take advantage of these note cards, and if in any moment of this summit a question comes up, jot it down. We can try to answer those questions towards the end of our program. And now, before we move into science and education, we begin where every journey truly starts, with a story. Because behind every diagnosis, there's a person, there's a family, a life. And instead of bringing someone up to the stage, I am going to walk down here and find someone. You're my victim. Let me grab this chair. Okay. What's your name?
Pamela Fernasiak Diaz.
And are you a caregiver? Are you living with Parkinson?
I am living with Parkinson's.
When did you find out about your diagnosis?
Unofficially, when I was in Miami, a neurologist said, I think you may have an atypical Parkinson's, and I walked out and never came back.
Wow.
It's complete denial at the beginning.
And what were some of your symptoms?
Well, I traveled a lot. I worked for IBM, so I traveled 2 or 3 times a week. I had fractured a foot, and I had a shoulder injury. So I just thought it was affecting my left side. But I just believed it was because I was traveling, lifting luggage, etc. That was my biggest symptoms, and very off balance. I fell quite a few times.
Once you decided to pass the denial, right? Mm-hmm. How did you take that?
Well, what happened was I was going to an orthopedic doctor, and he took all the different kinds of tests, and he said, you know what? I think you need to see a friend of mine, Dr. Rodriguez. And so when I went to see Dr. Rodriguez, he basically, looked at me and said, I'm pretty sure you have Parkinson's, but we're going to do a series of tests, which, validated it. And he gave me a lot of hope. He said, you're not going to die from Parkinson's. You might die from something else, but you're not going to die from Parkinson's. So that gave me, I then kind of took a turn, prayed a lot, and said, you know what? I need to embrace this if I'm going to live with this.
What has Parkinson taught you?
Number one, that every person's journey is different. I belong to a group called Rock Steady Boxing, where we do boxing for Parkinson's, and they do all sorts of balance exercise and weights and cardio. And each one of us has a different journey, and we need to embrace our own journey, right? And it's never over. I equate it to that game in the arcade where you have the 5 little men popping up. You get 3 down and then 2 more pop up. It's like you're never done. But it's just part of the process, I guess.
What's your message to someone that perhaps got diagnosed with Parkinson? It's afraid, right, of the unknown. Mm-hmm. What's your message to that patient, and what's your message to the caregiver?
Number one, I think you need to embrace it. It takes time, and everybody has their own time to do that. You need to do your research. There is so much available, so much available. I've done the physical therapy. Like I said, I do the rock steady boxing. I do something called osteopathic manipulation therapy, OMT, here in Lake Nona. I take probiotic, which is supposed to be good for Parkinson's, who knows? But I think you need to embrace it and become your own supporter, right? And just believe that you can conquer this. I was a part of a 1-year, clinical trial. I highly, highly recommend that. There was one that I thought, I would be able to be in, but unfortunately I've had Parkinson's for too long. There's so many clinical trials out there. You need to embrace it.
And I think it's important, right? Thank you for sharing your story. I think it's also important to let people know that you're not alone.
Exactly, exactly. We as a group, we get together for lunch. The women part of the group get together also for lunch. And it's great. You need the community. And you need, the other thing that happens when something new comes up, right away I'll message Dr. Rodriguez, I'm sure he hates me sometimes, but I said, hey, now I'm getting these pains, in my pelvic area. But right away we're able to resolve the issue. So you have to, I just find so much of it comes back to Parkinson's. And you need to embrace it, and you need to educate yourself and be your own advocate. And then I am fortunate that I have a daughter and son-in-law who happen to live right next door, who support me 100%. Right now, I don't need them as caregivers, but I know they'll be there for me.
Thank you so much, Patricia, for sharing your story, for your strength, your resilience. And she's not alone. You're not alone. And this is why I love this summit. Yes, a big round of applause. This is why I love this summit, right? We get to hear stories like Patricia. We get to explore all the resources that are out there. We get to hear from these experts that remind us every single day that we're not alone and we're in this together. Now, I'm going to ask Dr. Ramon to come up here because I would like for you to introduce our amazing keynote speaker today.
Thank you, Giselle. Good morning. Wow, it's great to see that every year we have more and more people coming to the Brain Summit. And, for us, this is humbling, right? We really put a lot of effort into this. Actually, Eduardo, who is right there, he's the engine behind this. Like, he's the Superman doing this. And, Eduardo is not only the organizer of this event, that he does everything, but he's also Dr. Bennett's husband. And this guy is a phenomenal father, like somebody that is there with his kids, like taking care of every sports event and just everything that is happening. So, Eduardo, thank you so much. Humbling experience. So now I want to introduce Dr. John Morgan, and to me this is a great privilege because John has been a man who has dedicated his life to unlocking the complexities of brain conditions and neurological disorders. And John is a professor of neurology at the Medical College of Georgia in Augusta. And right there, he serves as the director of the Movement Disorder Center and the Memory Disorders Program. And he's actually the leader of the Georgia Memory Net Diagnostic Center. For over a decade, Dr. Morgan has served as the director of the Parkinson's Foundation Center of Excellence at the Medical College. And this is only one of a handful of social lead centers in the country. Dr. Morgan has a PhD in developmental neurosciences as well. He is a physician. He is a board-certified neurologist as well. He has published over 100 research papers to his name. And he has been a true titan in the neurodegenerative research environment. But beyond titles and the academic accolades, what truly sets Dr. Morgan apart is his perspective. As a neurologist who is himself living with Parkinson's disease, he brings a level of empathy, resilience, and clinical insight that is truly rare. He doesn't just treat this condition, he understands it from inside and out. He has been recognized as one of the top educators at the Medical College of Georgia, and is a tireless advocate for patients across the state. Please join me in welcoming Dr. John Morgan, who's a brilliant researcher, compassionate clinician, and a true leader in neurology. John. It's great to have you.
Thank you. Whoa, bright lights. How are y'all? I'm John Morgan. I'm a neurologist and a Parkinson's patient as well, just like you, many of you. And I'm from Augusta, Georgia now. I grew up in Jacksonville, Florida, up the road a bit. And Augusta, if you don't know where it is, there's the map, right on the border with South Carolina. The Savannah River separates South Carolina and Georgia, and I live right there in Augusta. And Augusta is well known for what two things there? What is pictured? The Masters. What hole is that? 12. The tough par 3. You got to try to land it over the trap and onto the green and not go into the azaleas. So, have I played it? Yes, once. Have I been there? About 8 to 10 times probably, something like that. So I've been lucky to go to it. When you're local, it helps. And who's in the upper left? I feel good. Yeah, James Brown, the godfather of souls from Augusta, and other folks are from Augusta as well. Hulk Hogan was born there. A few famous folks are from Augusta. Who on television today portrays someone with Parkinson's disease? Michael J. Fox does. Alan Alda. But like, who portrays it in the show that they're in? Harrison Ford. Do you like shrinking? Okay. If you are not have no interest in shrinking financially, but if you are not watching Shrinking, it's kind of nasty and dirty and funny. Okay, I'll just put it that way. Foul-mouthed. You got to handle that part of it. But it is so funny. You will laugh and cry every episode. Okay? Harrison Ford is playing a man with Parkinson's disease in that show. And it's a very interesting portrayal of Parkinson's. And there's a new phrase that how they deal with Parkinson's, but I won't use it today, if you know what I'm saying. So, what did the phrase "you've come a long way, baby" come from? Do you know? Yes, Women's Lib. 1968, it was a Virginia Slim cigarette campaign. You've come a long way, baby. Encouraging women to smoke out in public versus not. And everybody in this room has smoked before, right? No, Parkinson's patients have never, ever smoked, usually, right? It's protective. We'll talk more about what's protective or not. But, and I want to talk about lots of things, but I know we have all kinds of folks from early disease to later disease today. I'm going to talk about PD 101. We can all learn more about that. Most bothersome signs and symptoms of Parkinson's, determinants of health-related quality of life in Parkinson's disease, what we treat well in Parkinson's, what we are not great at treating. This is probably one of the most important things in your life orientation. Is the glass half full or half empty? So hopefully you look at it half full. Look at what you can do and not what you can't do. All right, I like to keep it interactive. Upper left, who has what? Janet Reno or Gene Simmons? Janet Reno had Parkinson's disease. She passed away a while back. She was the Attorney General under Obama. Gene Simmons, this kind of illustrates who gets Parkinson's and who doesn't. We're all the Dudley Do-Rights of the earth in the room, right? Parkinson's patients have a personality, more not wild side, so to speak, folks. Average folk get Parkinson's disease. Gene Simmons, the lead singer for Kiss, the rock band, would be the person that would not get Parkinson's disease as much. The risk taker, the dangerous person, not just because they die of an accident or cancer or things like that, but they are less likely to have it. So African Americans and Parkinson's disease, it's out there, but I think it's a little less than the other races, and we'll talk about that. Who's that there with a CD in his hand? Back when they had CDs. After the love is gone, what used to be right is wrong. Earth, Wind, and Fire's lead singer, Maurice White. He had Parkinson's disease. He passed away not too long ago. Muhammad Ali points out that probably head trauma can lead to dementia and Parkinson's disease in some patients. There's a video of Hitler that shows that Hitler had Parkinson's disease most likely as well. A Smithsonian Institution video that was not edited out, making the Fuhrer look bad, but he had Parkinson's disease. It spares no one. Golden Girls, who's left? No one. They've all passed away. But the youngest one, Estelle Getty there in the red, mom, she had Parkinson's disease, and she later develop some complications from that. What are the 3 people in there that don't have Parkinson's disease? What's he got? Yeah, so he has a significant, on the videos that I've seen lately, he's had significant essential tremor, most likely. It looks like that, or drug-induced tremor. He's got philandering, that's a condition. And he had heart disease. He would stop at McDonald's on his runs, I think, and had heart disease. He was a vegetarian for a while. The Pope had Parkinson's disease. Michael J. Fox is illustrated there. Dudley Moore, no young person that I ever talked to knows who Dudley Moore is, but all of us know. And he had progressive supranuclear palsy. Who's famous that passed away with PSP recently? Jesse Jackson. He had PSP. Robin Williams was somehow acting and still doing a movie, Jumanji, with dementia with Lewy bodies. He was able with that. And Billy Graham in the bottom left there was said to have NPH, normal petrohydrocephalus, water on the brain, essentially. Charles Schultz had it, Salvador Dali, Yasser Arafat. So James Parkinson in 1817 wrote an essay on the shaking palsy. Involuntary tremulous motion would lessen muscular power in parts not in action. So tremulous motion in parts not in action when you're not moving it. And even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace. Does anybody ever do that in the room? You get going, can't stop, or have trouble stopping? Okay. Not too common, not too uncommon in practice. And the senses and intellects being uninjured. So he didn't know about what senses being changed in Parkinson's disease. What senses changed? Smell, that's a big one, right? Your vision is different as well with Parkinson's disease. And even taste has a little data that it's a little different. And it can affect your memory over time. Jean-Martin Charcot is the father of neurology. He described Parkinson's this way. He was in Paris at Salpêtrière Hospital. I've seen such patients everywhere in Rome, Amsterdam, and Spain. They reflect always the same picture. They can be identified from afar. You do not need a medical history. That'd take my job out of the way, wouldn't it? But no, it's not always that straightforward because they didn't recognize that there's different flavors of Parkinsonism back then. Drug-induced, Parkinson's disease, PSP, multiple system atrophy, etc. How do you avoid getting Parkinson's disease? Some of us in the room, and maybe a little late. But you can tell your family and friends this. None of these are fun. Die young. So it's a disease of aging. Essential tremor is a disease of aging. Alzheimer's is a disease of aging. Aging does bad things to our brains. Smoke. How many doctors tell you to smoke? So smoking is associated with lower risk if you have significant history. I can count on a couple of hands the number of smokers that were heavy smokers that developed Parkinson's disease in my practice over the years. It's not common to see. Drink a lot of coffee. The more coffee intake you have, the less Parkinson's risk. Non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, those kind of things can lower your risk. Exercise can. Don't get fat midlife. Dwell in the city. So city folk are less likely to get Parkinson's than rural folk being exposed probably to pesticides or other chemicals. Poop regularly. How many would you like that? Right? So there was a study in the Japanese Asian American group of patients. Those that had the most frequent bowel movement frequency, the highest bowel movement frequency per week, had the lowest Parkinson's risk. Those who went less had higher Parkinson's risk later. So why could that be? Well, either it may be a pre-symptomatic thing that you're manifesting before you show up with Parkinson's, or it could be that you have food in your gut and you're absorbing more of the chemicals that are the pesticides longer, maybe. Elevate your uric acid. So higher uric acid was associated with gout, essentially, is associated with slower progression. Farmer, teachers, and healthcare workers have higher risk. If you drink well water, you may have higher risk. Choose your family wisely. We're all screwed on that. Too late. Live an adventuresome and dangerous lifestyle. Parkinson's patients don't take a lot of big chances usually. They're not dangerous. But If you have an adventurous, dangerous lifestyle, you tend to not get it. Eat lard, again, your doctor never tells you this. Higher LDL, lower Parkinson's risk. The more milk you drink, the higher risk. Excessive daytime sleepiness is a risk factor, and then men get it more often than women. So Parkinson's goes up by a decade, higher incidence, and then it drops off in the 9th decade to a little lower level. But the incidence rate per 100,000 person years steadily climbs as we age. Average age of onset's about 60. There's at least 1 million folks in the US that suffer with Parkinson's, and in most clinics, it's about 60 to 40 men to women. Young onset Parkinson's is before the age of 40 to 50. The definition of the cutoff of that is variable in various literature. Juvenile onset Parkinson's disease is before the age of 20, and up to 75% of those patients that have really young onset Parkinson's, they may have a Parkin mutation in their genetics. Dystonia and psychiatric disturbances are more common. They have early motor complications like wearing off and dyskinesia and those issues. And treatment is designed to delay or reduce those motor complications. Again, if you're a young patient with Parkinson's disease raising a family, like I am, it's a lot different than you're 75 and retired and you have a different set of priorities in your life. So I'm sweating, how long can I work? Can I make enough money to retire on? What's my wife going to do when I get more progressed? All these kind of things. So you think about those things for your patients, and it's a different approach. There's also a thing called LRRK2-driven Parkinson's disease. I think Ramon's going to talk more about that today in a research study. But 30% of Parkinson's disease may be driven by a gene called LRRK2. So race in Parkinson's disease, Hispanics probably have a higher percentage of Parkinson's patients compared to whites, to Asians, and blacks. And that was done in the Kaiser-Permanente system. So it's not hugely different, but certainly we see fewer African Americans, and it may be how folks seek care or trusting the medical system may differ. How many of you presented with these complaints? I heard walking was your first complaint, right, ma'am? Was walking a big issue? Yeah, so balance and dragging a leg, those kind of things. But classically, what most people come to my clinic for is tremor, resting tremor on one side. That's the most classic thing that I see. And I ask them, are you slow and stiff on that side? They may notice that secondarily, but the tremor is what bothers them and gets them to care most often. Depressed mood, slow daily living activities, vivid dreams, softened voice, hunched posture, reduced facial expression. And there's a lot of unrealized problems related to Parkinson's disease that people don't realize, like constipation, loss of sense of smell. A lot of folks are not even aware they lost their sense of smell. The spouse may be, but the patient maybe not. Depression, anxiety, social withdrawal, and masking of facial expression. So this paper was from 2025, Michael J. Fox Foundation paper with data looking at early stage Parkinson's disease and the most bothersome symptoms. These folks had Parkinson's less than 2 years. There were at least 8,500 respondents to a survey. And as almost always with Parkinson's disease, it's all white people in studies. We need to have more folks with diversity in studies to make more broad conclusions. But 96% white, 53% men, and the average age was 65. So motor-wise, the most bothersome symptoms in early Parkinson's are tremor. There's that altered gait. Impaired dexterity or small handwriting, altered balance, slowness, stiffness, etc., and then below that's 10%. But tremor, gait, impaired dexterity, balance, slowness appear big ones. Non-motor symptoms, there's a bazillion, aren't there? But look at, that's surprising to me, but pain. How many of you experience a lot of pain with your Parkinson's disease? How about some pain? Little pain. Okay. Yeah, most folks have little pain with Parkinson's that I see in practice, but I guess it's more bothersome than I realized. I don't have much pain with my Parkinson's disease. Physical fatigue. What makes your fatigue better? Exactly. Very poorly researched, very poorly understood. We don't know how to treat fatigue that well. Exercise can be useful in fighting that, making sure you sleep well, those kind of things. Anxiety and worry. negative emotions or cognition, altered speech, trouble with memory. All of those are the higher prevalent symptoms. But the biggest predictor of health-related quality of life in Parkinson's, out of all those symptoms and signs, is depression in multiple studies. If you have depression, get on top of that and treat that, because that is one of the most important things you can do to improve your quality of life. Look at it this way. If you look at the glass as half empty all the time, everything's going to be half empty, right? And so you've got to get on top of that and treat that. Treating fatigue with exercise, making sure you're sleeping well. If you have sleep apnea, treating that, wearing your CPAP and not taking it off at night. Anybody do that? Everybody does that. Or you wake up with it off. And then motor function limitations is the third. So those three: depression, fatigue, and motor function problems. The cardinal signs of Parkinson's include bradykinesia, slow movement. How do we do that? Dr. Rodriguez and Dr. Benez will test your finger taps, right? Open and close your hand. Flipping back and forth with, can you see my right hand slower than my left, or less amplitude? Okay. So that's what you're looking for, amplitude of getting over and back, okay, for bradykinesia. Cogwheel rigidity you test by wiggling someone's arm, and you can feel it have a ratchet in it as you move. It catches as you move their arm. You will move their wrist around in a circle. You can feel the cogwheel rigidity with that too. Resting tremor is present in about 75% of folks. Not everybody has it. And then postural instability and gait disturbances happen later with Parkinson's disease, but they happen in early patients, as you saw in the last slide or two as well. But the postural instability on a pull test, where they pull your shoulders like this, and you take a step back and catch yourself. If they don't pull you hard enough to take a step, they didn't pull you hard enough, okay? So you gotta pull you, so you make sure you take a step. And then different folks have different strokes with that. An early patient will easily step back and catch themselves. A middle stage patient may take multiple steps and catch themselves. And then an advanced patient or a PSP patient may fall like a log. Okay, the beam sign it's called. So Flash is a good example of bradykinesia. Have you seen Zootopia? Funny movie. Flash is a sloth. It takes him forever to express himself. He is definitely bradyphrenia, slow thought, that kind of thing. But it can take 2 or 3 times as long to perform tasks. You can have reduced facial expression, slowed everyday movements. And Fast Eddie, I wrote it down here because of my high school experience. I didn't know my trigonometry teacher in high school had Parkinson's disease, but my friend called him Fast Eddie as a joke, and I didn't get it. I said, I guess he's just old. But then looking back on it, he had Parkinson's disease. He hand wrote his tests for trigonometry, and it had micrographia. I was like, why does he write so small? I didn't notice it then, but I had no idea in high school what Parkinson's was. Had not been around it. But yeah, you can see it out in public many times. Tremor is present in 75% or more. It's resting tremor. It typically starts unilaterally. My tremor started in my right foot. I was one day sitting in a chair in the office, and I said, oh, I'm just leg jiggling. Why is it going on after I quit leg jiggling? And it was tremor. So, yeah. Tremor of the foot is almost always Parkinson's disease. There's very few things that cause tremor of the leg. It improves when you move the affected limb, typically. It increases with stress or anxiety or during sex. So lots of things can happen. ET versus Parkinson's. How many of you were diagnosed with ET first before you came to the practice? Not uncommon to be diagnosed with that, Parkinson's, or both, okay? So you can have a lot of the features of ET and Parkinson's disease, like you can have tremor when you're reaching for a finger to nose. You can still shake with Parkinson's disease. But ET typically affects the head, the hands, and the voice. Who's the classic picture postcard of ET? Katharine Hepburn, that's exactly right. She had a classic voice tremor. Hello, Henry. And her hand shook when she put them out or did things. Usually beta blockers and alcohol. Alcohol responsiveness is classic for ET, not so classic for Parkinson's disease. Levodopa responses is more typical of Parkinson's disease. And your hands, legs, or mouth may tremor with Parkinson's, or jaw may tremor with Parkinson's more so than the head, hands, and voice. And micrographia is part of the Parkinson's. Cognitive rigidity, we talked about that already. And we talked about the pull test, stoop posture, freezing when turning or going to door frames. You hit a door frame and you're like stutter stepping, or you turning, called turning en bloc, E-N space B-L-O-C, a French term, where you turn in a shuffly way. Small handwriting is classic. Today is a sunny day in California is what's written there. Decreased arm swing on the side where the Parkinson's began. That's a classic feature. Hypomimia is the masked face. Hypophonia is the soft, hoarse voice, which God's cruel. Well, just saying, just joking. But he gives your spouse hearing loss while you get Parkinson's and have a soft voice. Just not fair. It's very tough. But you can do a lot to fix a lot of these things. Decreased arm swing, big therapy helps you focus on amplitude-based movements with LSVT big therapy. Hypophonia can be markedly improved with LSVT loud and speak out therapy and other speech therapies. James Parkinson recognized many of the features of the disease that bears his name, but he described non-motor features in this slide. In this stage, the sleep becomes much more disturbed. The bowels, which have been all along torpid, now in most cases demand stimulating medicines of considerable power. The expulsion of feces from the rectum sometimes require mechanical aid. That's bad constipation right there, right? And that happens still today. Gut motility from mouth to anus is a problem in Parkinson's disease. There's also defecatory dysfunction. Some of you may have that. That's where you're going to poop, and your bottom doesn't relax and force the stool out at the same time. You can't contract the muscles in the right order, and so that happens too. So there's defecatory dysfunction and motility issues. All of this can be helped significantly with medications and therapies. Biofeedback can be helpful as well. So a lot of non-motor problems in Parkinson's disease involving the autonomic nervous system, urination, sweating abnormalities, especially with wearing off, temperature dysregulation, orthostatic hypotension, fatigue, pain and burning dysesthesias, visual changes. Up to 15% of patients with Parkinson's complain of double vision, impaired color discrimination, and then the rougher ones to live with the neuropsychiatric ones like depression, dementia, and psychosis and hallucinations. Those are harder as the disease progresses. So sometimes you pray for a bad sense of smell. So these ladies are testing, I think, deodorant effectiveness. Hope they got paid a good salary because it's a tough job. But the olfactory function is early with Parkinson's disease. So that's very early, 10, 15, 20 years before you develop the motor features of Parkinson's. What are the other two features that can precede the motor features by 15 or 20 years? Constipation. And how many of you have gotten beaten up in your sleep? REM behavior disorder. So rapid eye movement sleep or dreaming, and you're fighting, and you sock your bed partner and knock her off the bed, and she wakes up, what the hell are you doing? You knock the lamp off, and you're having a dream fighting someone off. So that's called REM behavior disorder. REM, loss of sense of smell, constipation, three things that can precede the motor features of Parkinson's by 15 or 20 years. So you may not discern blue versus green as well with Parkinson's disease. Visual spatial discrimination is more difficult, and visual hallucinations are more common with ocular problems. So if you have like a glaucoma or a cataract or issues like that, macular degeneration, you're more likely to have hallucinations than not. Hallucinations can be scary. This is a drawing of one patient's hallucinations in Parkinson's disease, and you can see it's an amalgamation of different figures and things and people. If someone hallucinates the same person all the time and they died like last year, that's not a hallucination. Or maybe a hallucination, but it's a grieving reaction, right? They're still grieving over that person. Usually patients with hallucinations of Parkinson's have varied hallucinations. Different things happen. And then there's the question of, is it a hallucination or do they wake up and continue a dream? You wake up out of a dream and you think someone's knocking at the front door or broke in the house, and you go get the gun. Why is that important? In Georgia, we got folks have guns. And one guy was my patient. He thought he saw a hallucination of someone breaking into his truck. he pulled out a shotgun. He said, "You better get away from my truck." And then he blew the window out of his truck with a shotgun. It was a hallucination. So safety is real important as patients get more confused down the road with hallucinations, things like that. Very important to be safe about that. Fatigue is prevalent throughout Parkinson's. It may affect over half of early Parkinson's patients. It's associated with anxiety, depression, reduced motivation, and apathy. Apathy is you're happy doing nothing. Okay, some folks are like that. Parkinsonism, severity, and pain. There's little data on treatment. There was a paper of Versagiline, Azilect, that showed that it reduced fatigue, and exercise may be helpful as well. Sleep disturbances are so common in Parkinson's disease. At some point with Parkinson's, you have about a 100% chance of having a sleep problem, ranging from REM behavior disorder, like we talked about, to nocturia interfering with your sleep, pain, depression. There are lots of medications that can be tried. Trazodone, clonazepam we use sometimes, but only in select patients. Mirtazapine, melatonin can be helpful as well. Pain symptoms. 50% of folks complain of pain. 40% have sensory complaints of burning, tingling, and numbness. It may precede the Parkinson's motor features, and maybe on one side of the body. Treatment can sometimes respond to anti-Parkinson's drugs. So if they have a dystonic type pain, they can help with that, with off dystonia. But anti-epileptic drugs, narcotics can be helpful as well. Where are you on that scale? That's the poop scale. So if you're type 1, you're not loose enough. Sorry for ruining your breakfast. But you're hoping for type 3, type 2, 3, or 4. So, but a lot of folks will note that they have a very hard stool ball that they try to pass to begin with their constipation with Parkinson's disease, and then they eventually get that through, and then things start flowing. But routine use of enemas, stool softeners, bulk forming agents, Miralax can be helpful. As I mentioned, it's the early sign of Parkinson's disease. Increasing physical activity can be helpful. If someone is on anticholinergic drugs, backing off on those can be helpful. And then other GI problems, and I mentioned the motility from mouth to anus. Drooling is a common part of Parkinson's disease for many folks and bothersome. So that can be helped with glycopyrrolate or botulinum toxin injections into the parotid glands and the submandibular glands. And then dysphagia can be helped with different techniques as well. Orthostatic hypotension, your pressure drops when you stand up, okay? And it amazes me that in the cardiologist office or the primary care office, a lot of times the patient complains of standing up and feeling lightheaded, and they have never had their orthostatics checked. So if you have not had your primary doctor check you if you're lightheaded when you stand up, make sure you ask them to check those blood pressures lying and standing, okay, to see if it drops. You can be orthostatic by pulse or blood pressure. But removing meds that lower blood pressure too much, elastic stockings to help return blood flow back, salt in your diet, sleeping upright, and then there's medications that increase salt intake like fluzocortisone, midodrine, which gives you squeeze of your blood vessels, and droxidopa, which converts to norepinephrine and can help with squeeze as well. Urinary problems, nocturia, hesitancy, frequency, urgency. After 20 years of Parkinson's, 71% of folks were incontinent. Be careful of most bladder pills because they can make cognition worse, okay? So most bladder pills are anticholinergic, and they can make cognition worse. They can also reduce tremor sometimes too. I had a patient take Urobel, which is belladonna, over the counter, and his tremor was better, but he had less cognition on it. Mirabegron and another drug in the same class, I can't remember the name of right this second, but mirabegron works through beta-3 receptors and does not worsen cognition, so it can be helpful. And then sometimes with nocturia, you can use DDAVP, a hormone, to reduce secretion at night. So sexual dysfunction is common in Parkinson's. It can be due to drugs, depression. Ramon's former group at the University of Florida studied testosterone deficiency and found that in Parkinson's patients. Sildenafil and tadalafil medications can be helpful. And Augusta's famous for another reason. What's that on the right? No. Think about middle of the body. Penis pump. Yeah. Augusta's famous for the penis pump. Osmond Medical Systems developed it there. Medical students would staff the phone lines with some very interesting phone calls. And they sold it, I think, for $30 million. Yeah, that's a lot of pumps. Testosterone supplements and injections can be helpful as well. So there's lots of different diagnoses that can look like Parkinson's disease. All of these are potentials when you walk in the door, okay? Patients with advanced essential tremor can have Parkinsonian-looking features. They can be a little slow. They can be a little, have resting tremor even, like Parkinson's patients. So it can be a little confusing for an advanced patient. But all of these are on the differential diagnosis. DAT scan. How many of you had a DAT scan in the room as part of your workup? Good number, okay. So DAT scan shows that comma-like appearance that you see in the upper left there in a normal patient. See the two commas, the period and the curly Q? But with Parkinson's disease and its cousins, PSP, multiple system atrophy, all of these other cousins, you lose the tail of that comma in an area called the putamen. And if you lose the tail on one side more than the other classically, you tend to have Parkinson's disease. These patients here took what drug? That was a designer drug out in California in the 1970s. MPTP. They were trying to get synthetic heroin on the streets. And MPTP was discovered after these folks started showing up in the ER with Parkinsonism as it killed dopamine neurons in the brain. And so MPTP has been a drug that's used for animal models ever since. You got water on the brain. That's what the doctor says. You got water on the brain. Ramon, do you feel comfortable with NPH diagnosis every day and shunting? I don't. I struggle with it. There was a paper that just came out in the New England Journal of Medicine about NPH, where you have big ventricles and shunting. And it showed that overactive bladder symptoms did not improve with shunting. Cognition did not improve, but gait did improve. So if you already have a patient that has some dementia or significant dementia, it's kind of, you're questioning whether to do it or not. It's a very difficult thing. Some places believe in it a lot, some places believe in it a little. But I still struggle with it after 20-something years of practice. Lowest diagnostic accuracy in early Parkinson's. Pathologists are the best at diagnosing because, well, you're a captive audience, you're dead. Movement disorder specialists are probably the second best. Neurologists in primary care, maybe 50% correct, according to one study. And then more difficulty with akinetic rigid, the stiff folks without tremor. Accuracy improves over time. And if you take levodopa and you have Michael J. Fox dyskinesias, okay, if you have dyskinesias, you have a 95% chance at autopsy of having Parkinson's disease. Only 5% chance not. Typical progression of Parkinson's disease, there's a preclinical phase that probably is much longer than 6 years. And then a honeymoon period where you're taking your levodopa, a honeymoon like your marriage. It was perfect the first few years. And then motor complication period, levodopa-resistant symptoms come in where you have depression maybe or dementia coming on, and then cognitive decline happens in the long run. There's different ways to measure Parkinson's progression. Hoehn-Yahr staging. Most folks come to the clinic, they're stage 1 or 2 at first presentation, but usually stage 2, they already have bilateral involvement. But some stage 1 folks with just one side involved. Stage 3, you start having postural instability and then beyond there. So how much time do I have left, Ramon? Am I out? Am I out of time? 5 more minutes, okay. I gotta go through a lot. Don't worry, these slides that you can have, by the way, they can share my slides with everybody. They're for your reference to take if you want. But the loss of dopamine neurons in the substantia nigra is associated with the appearance of these red structures in the bottom right there. What is the red structure with a halo around it? The Lewy body. Have you heard of the Lewy body? So Lewy body is made of alpha-synuclein protein clumped up in a ball. And it's a sign that those dopamine neurons have a process going on with alpha-synuclein clumping up and the cells dying. So in a normal brain, you see a nice black stripe in the brain tissue. In the folks with Parkinson's disease, those pigmented neurons have dropped out, like you can see in the bottom left. And that's the cause of Parkinson's disease, is loss of these neurons. Why it happens, we don't know yet. It leads to a dysfunctional physiology in the brain, where your movement is not regulated appropriately. Normally you have not too much movement, not too little movement. You have Goldilocks movement just right. But with the loss of the substantia nigra neurons, the dopamine, you don't have as smooth a movement. So why would someone develop depression in Parkinson's disease? Well, their 5-HT is low, half of what the controls are. What is 5-HT? Serotonin. So if your doctor wants to put you on a serotonin reuptake inhibitor, SSRI, it may be helpful for your depression. There's organic chemical basis for it. Where does Parkinson start? The brainstem, and it goes on up into the brain. The olfactory bulb. This is a staging criteria that was done by Brock in 2003. But the substantia nigra is not involved initially. It happens later. We don't know the cause of Parkinson's disease still. We know that proteins aggregate, mitochondria, the powerhouse of the cell, don't work right. There's a lot of oxidative stress, a lot of inflammation, and a lot of excitotoxicity, and cells die. We know that there's gene input and environmental input, but we don't know exactly what the cause is. Treatment options: watch and wait, clinical trials, medication, surgery, rehab therapies, exercise, and complementary therapies. There are drugs that work outside the blood-brain barrier, out in the periphery, to get more levodopa into your brain, like those on the bottom left. Levodopa is the gold standard of therapy, and it's converted to dopamine inside the brain to replace dopamine that you lost. With motor complications, you can have wearing off as a classic one, or dyskinesia that develop writhing and twisting movements. And dyskinesias can be improved by reducing levodopa dose, but you may have more off time, so you're trying to balance that. Manthanine or manthanine extended release can be helpful. And then wearing off can be treated with adding any of these different drugs or clinical trials. The holy grail of Parkinson's is disease modification. We have had recent failures. I put forward pioglitazone as a candidate and helped develop that clinical trial. And all of these others went through extensive testing with negative results. Under study still are gene therapy, stem cells, GLP-1 agonists. That's under study for everything, isn't it? Alpha-synuclein immunization, small molecule inhibitors of alpha-synuclein, and antibody infusions that prevent the spread of alpha-synuclein between neurons. Have you heard of tavapadon? Tavapadon is a new drug that's with the FDA, with a new drug application from AbbVie. Are you talking about this one? Okay, he's gonna talk about it later. But very interesting results. Just published last week in JAMA Neurology, and he'll tell you about that. Skin biopsies can be helpful for Parkinson's disease diagnosis and other diagnoses. But it's in the clinical trial that was published, folks had 4 years of disease of multiple system atrophy. After 4 years of multiple system atrophy disease, you can tell usually clinically whether someone's different. So these techniques are helpful, but not as timely as we would hope. So exercise and therapies, move it or lose it. This lady gets a lot of dates. But if you take mice and give them the MPTP chemical that kills dopamine neurons, and you exercise them versus sit them around and have them do nothing, the mice that exercise do better clinically and with better function. Tai Chi for gait and balance was shown to be helpful in the New England Journal of Medicine paper in 2012. Tandem biking can be helpful. Doing LSVT loud or big therapy can be helpful. And the problem is short studies, small numbers, variable measures, and no control group. I'm almost done. All kinds of exercise improve severity and signs of motor symptoms and quality of life in a randomized meta-analysis study. There's no specific form of exercise that was clearly beneficial over others. Adverse events were likely underreported or uncommon. And how many of you play pickleball? 400 million of Medicare claims from pickleball injuries. I'm healthy, but I broke my leg. So be careful. So disease modification remains the most important unmet need in Parkinson's therapy today. There's tons of novel therapies that may slow down PD progression, but are we studying them long enough? That's the problem. I just talked to a company the other day. They have a trial for 6 years coming up for a drug, which is great. So hopefully we'll get a better answer. The longer you do a trial, the better data. Wearing off remains the most researched area of Parkinson's disease. Dyskinesia remains an important area of target as well. Levodopa remains the gold standard therapy, and it's helped lots of people live with Parkinson's disease. Delivering at more extended release is a better way to go, I believe. Devices and AI will aid clinicians in the diagnosis and treatment of Parkinson's disease and related disorders. Exercise should be a part of everyone's regimen. No matter what stage you are, you should be doing some sort of exercise, okay? Cognitive, physical, both. And remember, the glass is half full, not half empty. Thank you.
Thank you, Dr. John Morgan.
Thank you.
Thank you so much for sharing all of that wonderful data and also for those moments of humor, right, that you shared during your speech.
You gotta laugh.
You have to laugh. Now, are you guys having a good time? So much information, and this is just getting started. Now, we want to move on to our next session. Parkinson's does not affect everyone the same way. And this next conversation focuses on how the disease uniquely affects women. Please join me in welcoming Dr. Lourdes Vélez, a board-certified neurologist and medical director of Neurology 1 with over 20 years of experience in Parkinson's disease and memory disorders. Dr. Cielo Ñeco, board-certified OBGYN with Orlando Health Women's Institute, dedicated to women's health across all stages of life. Dr. Sandra Rodriguez Davila, an adult and geriatric psychiatrist with over 17 years of experience specializing in mental health and neuropsychiatric care, for this session called for Women in Parkinson's, Understanding Hormones, Mood, and Brain Health.
Good morning, everyone. So glad to see so much familiar faces, and very happy to see all of you. But more than that, I'm very happy for each one of you that are taking control of the condition. You're not here because of me. You're not here because of Dr. Rodriguez. You're here because you want to learn, right? You need to be empowered, and you need to advocate for yourself. And now, talking about women, that's the reason I chose this topic. We don't have that many research in women. And the data that we're using right now is the data that has been mainly obtained for men, and we are different. So for those of you who doesn't know me, I'm Eduardo's wife, and Camila, Victoria, and Gustavo's mom. And Gustavo, when he came here and saw that picture, he asked me, where was my picture? And I was like, what do you mean? And he said, well, Mommy, if you're the one on the left, you had a lot of Botox before the picture. So anyways, that it might be the case, but I'm very happy to be here and share with you some important information, especially for women. And for that, I have the honor to present the panel, which is Dr. Cielo Ñeco. She's an OBGYN that works in Orlando Health. And Dr. Sandra Rodriguez, who is a psychiatrist that specializes as well in Parkinson's patients. And I also have a patient that is the most important person of this panel, so I would like you to join us as well, who is Amy Pempel, who graciously accepted our invitation to share her history. Because what I'm going to say, or what we're going to say, is not the same unless you hear it from somebody that is feeling it, right? And that is going through that. So welcome all of you. Thank you for the Parkinson's Association of Central Florida for joining us, and thank you for all the sponsors. Without them, it would not be possible. So take the time to go and stop in each one of them. They have valuable information to share with us. So, having said that, let's get this started. And I'm not going to be doing a lecture. We're just going to be doing a conversation. And we're doing that on purpose because I want to normalize this as much as possible. And for that reason, I choose this panel on purpose, and we're all women. And we have different perspective of what's going on. But what mainly differentiates men from women, or one of the things, are hormones. So you heard the very nice presentation that Dr. Morgan gave, which is what we usually do for all of our patients with Parkinson's. However, most of the data that he presented is different from what I'm going to say, starting by saying that I don't have a lot of data because a lot of women do not show up for the clinical trials because we're underrepresented. So the data that he told you, I mean, I know it's different, but I don't have numbers to show you any different than that. Before I start, I would like all of you to close your eyes. Bear with me with this. Close your eyes. And now picture, if I tell you, think about Parkinson's. What comes to your brain? What comes to your head? In general, I think, at least for me, I see somebody that is more than, in the 70s, something like that. A man, probably with a stoop posture, shaking, slow, maybe with a cane or maybe with not, and accompanied by a woman on the side. I think, at least for me, when I picture Parkinson's, I picture that. I don't see, if you tell me Parkinson's, I rarely would picture in my head a woman, but rather I do a man, right? So we need to start changing that because we get Parkinson's as well. Women do get Parkinson's. Now, we think that maybe hormones have a role, as I was saying, and it takes longer for us to get the diagnosis, like 2 years more than men does. And one of the things that have been brought up as a hypothesis is the hormone theory. So I will let the expert in hormones here, who is the GYN, to tell us a little bit more about the roles of the hormones and the possibility of the protective effect of the hormones, that then when we get to menopause, we start to, those hormones start to decrease, and that may be one of the reasons why we are diagnosed a little bit later compared to men. So, Dr. Cielo, tell me about the hormones and how the hormones play a role here.
So that's a complex topic, right? We know women's health is very complex and more so in the setting of Parkinson's disease. And I want to ask with one question to all the women here, and the question is, how often do you bring up your hormones or menopause to your GYN? And you can raise your hands. Not many, right? And thankfully nowadays, there's a little bit more awareness of how complex that transition can be for women, but it's still not enough. And like you said, there's also not enough research. But we do know, estrogen is that hormone that is slightly declining in that menopausal transition. And we do know that estrogen is protective. And this is likely one of the reasons why women with Parkinson's get diagnosed a little bit later in life, okay? When I was listening to Dr. Morgan's presentation and saw that slide that listed the most common symptoms in Parkinson's, I realized that there is a huge overlap. If I was to make a list of the symptoms that women experience during perimenopause and menopause, I could go on and on and on and write pages and pages of those symptoms. One of the most common symptoms in menopause is anxiety and depression. And I know we'll get into it in a little bit, but there is a huge overlap. And I think it's very important to address how important hormones are. Most women are candidates for therapy. And I think it's just very important to speak up about it. Because estrogen is important, it can be protective, and it can most definitely help women overall, and more so women with Parkinson's.
So what is your, how do you feel about the hormone replacement in women and in Parkinson? Should we go that route, or should we wait, or when should we do it? When do we go to the GYN and ask for that? If you have a patient that show up at your clinic and is having those symptoms, do you immediately check for the hormones, or what is your approach?
Yeah, so the only diagnosis we have for menopause is bleeding, right? So 12 months without any bleeding. But that doesn't mean that you won't have any symptoms beforehand. So yes, absolutely, go to your gynecologist. Some gynecologists tend to be specialists in menopause and hormone replacement therapy. I personally am a big fan of hormone replacement therapy because now we know that it can be so helpful to women. I have personally seen my patients come in with a full list of psychiatric medications, and I'm sure this is something that you see all the time, because one of the first presentation is those mood changes, right? The anxiety, the depression, the lack of sleep from the hot flashes. And the first thing they do is, get a workup for their anxiety and depression. But a lot of these women are actually being affected by those hormones, okay? Not everyone is a candidate. We have to take each patient separately, but most patients can be candidates for hormone replacement therapy, and we do now know that these hormones are safe. And a lot of you may be familiar with the Women's Health Initiative, which was a huge study that happened in the early 2000s, and it made us all very scared about using hormone replacement therapy because it showed, quote unquote, because it was actually ended early, that it was that HRT, or hormone replacement therapy, was associated with breast cancer and stroke and MI. And now we actually use completely different hormones that are very safe to use, and even when we use estrogen alone, it actually can decrease the risk of breast cancer. So I think it is so important to talk to your gynecologist. Start with your PCP, go to your gynecologist, talk to them about hormones or the many other treatment options that we have for women, because it can help you. It can help you with your daily living, and it can actually decrease your mortality rate as well.
Adding to that, I have to say that most of the patients, if not, that present with for a Parkinson's diagnosis to my clinic, and they're women, they do not present like Dr. Morgan said they present to his clinic. So the tremor is not usually the most common presentation symptom for female. Usually is mood changes, usually is depression, anxiety. And that's why it takes so long as well, right? It could be one of the other hypotheses, could be it takes longer for the women to go to the doctor and get diagnosed, because before that, they're going to the psychiatry, or they are at home thinking that, the anxiety that they're having is because of the dual role that they have. Most of them are caring for their husbands, or for, they have children themselves or grandchildren. So the typical picture of I get to the clinic shaking and slow is usually not the reason of the consults that I see in my clinic. And that brings me the other question for Dr. Rodriguez, psychiatrist, right? Because I do get some consults about, I'm here because of anxiety, and the anxiety has been very difficult to treat, or depression has been very difficult to treat by my psychiatrist, and she or he send or refer me to your clinic to see if there's a neurological disorder behind it. So the presentation of difficult to control depression or anxiety that does not respond to medications very well in a mid-age female could be one of the things that we see. What is your impression about that, about depression, anxiety, and somebody that is hard to manage, and probably thinking, let me just refer her to neurology because probably there is an underlying neurological problem?
Yep, absolutely. Is this working? Hello, everyone. Thank you for inviting me. And this is one of the reasons why Dr. Benes wanted me to come and speak, because the intersection between all of these different specialties, things cannot be entirely clear, And we have to be humble and say, all right, I'm not sure what's going on here, so I'm going to refer you. But this is also the reason why women tend to be diagnosed later, because we don't really focus on those symptoms. In my line of work, we're just talking about thoughts, feelings, behaviors. So it's a little difficult to identify when someone is having early symptoms, and especially women, where it is not the typical picture like Dr. Benes was describing. And also perimenopause. I get referrals just for mood swings, irritability, no psychiatric history, and then I sit down with the patient, and at the end of the consultation, I'm like, my friend, this is probably perimenopause. So, you know, all the intersection between all the specialties, it's so important to have people to consult with, because for us, it can be difficult to differentiate. And if you are just staying in your lane, then I'm gonna maybe miss a lot of things that other providers may be able to better diagnose. So
a multidisciplinary approach
exactly.
is very important. Now, our system, unfortunately, is what I call a fragmented system. And not necessarily you're going to see a team of physicians like we're sitting here discussing this topic. But that's the reason that I told you at the beginning, you need to learn, and your health is in your hands, and you have to advocate for yourself. And if you don't find the answer on the first doctor, go to the second doctor or to the third doctor and build up your team. 40% of the patients that have Parkinson's worldwide are women, so we are not the majority. However, we are the ones taking care of our spouses most of the time, because most of the caregivers still are women in general. And most of the women with Parkinson's have another woman with Parkinson's taking care of them. So it's not common, as I said, the presentation. So if you have any symptom that you're not sure what it is and it's not fitting in any diagnosis, and you saw the list of different symptoms that can happen that Dr. Morgan pointed out, remember they're non-motor symptoms, and I need you to be aware of those: anxiety, depression, hallucinations, sleep issues, fighting and kicking during the sleep, memory problems, swallowing problems, speech disturbances, drooling, anosmia or lack of loss of smell, constipation, erectile dysfunction, sexual dysfunction like decreased libido, pain. And most of those symptoms, besides the motor, those symptoms that I just mentioned are more common in women. So with that said, we're gonna all listen to from firsthand, from a patient that went through this, how long it took her to get the diagnosis, what symptoms she had, and how Parkinson's has changed her life. Amy.
Yes, thank you so much. Can you hear me? Yes, thank you. And I just have to say, this woman is incredible. I've been going to her for a couple of years now, and she's just phenomenal and really pays attention to each individual patient. So thank you, Dr. Benes. And my husband loves to come with me when I'm going to see her. I don't know why. And I like it when her husband walks in, so there you go. But I was diagnosed at age 59, which is about 6 years ago, but it did take a little while. I was in denial for the most part. I had the tremors. I knew something was up. My GP said it may be an essential tremor, so we did some medication and some testing for that. And finally she said, you know, you need to go see a neurologist, which I did. And unfortunately, the neurologist I went to was not very personable and just kind of had me walk down the hall to see if my arms were swinging correctly. Told me to go get a DAT scan, brought me back in, did not come into the room, sent his nurse in to tell me that I had Parkinson's. And so that was my first exposure to it. And then fortunately, I was referred to Dr. Benes by one of her patients, and my world changed because she really understood what I was going through. Most of the first things that I experienced after diagnosis was denial. I don't know how many of you just think, okay, I have Parkinson's, but I'm still doing what I've been doing. I might twitch a little more, I might have to take some extra pills in the morning, but it's not a big deal. I'm just going to go on with my life. And that's where I was. I was just in denial for the most part. But then I found the Parkinson's Association of Central Florida. I don't know, some of you may know John Gabriel. He was the general manager of the Orlando Magic for many years. And he's on the board of the association. And he invited me to come to a meeting and to observe and to see if I wanted to become involved as an advocate and sit on the board, which I've done. And it really opened my eyes to what women are going through, because most of the people on our board that are women are not actually patients, they're caregivers. So my perspective was a little more unique. I do find that I have the movements that are starting to get a little bit more pronounced, but I have the support of my husband, which is wonderful. I don't have any children, but my husband is there, but he also has some medical issues to deal with. So I'm serving not only as a patient with Parkinson's, but also a caregiver. So it's a double whammy in my household. But I just want to say to the women out there that, you know, you've got so much on your plate. And all of us, I was working at the time, I'm retired now. I had a house to maintain, lots of things going on, volunteering for various organizations. So I was very, very active. And the diagnosis came at a time where I was like, it's in the way. I'm just going to push it to the side and not think about it. But after joining the board of the Parkinson's Foundation of Central Florida, I realized that I can't deny it anymore. I have to exercise. I got to tell you, when I was in high school, PE was my least favorite class. I was not an exerciser. I never liked going to the gym. I'm not a gym rat. So forcing myself to exercise has been a little bit of a struggle, but I know it helps, and Dr. Bennett said to continue to do it, so that's what I'm doing.
And you're doing wonderful, and thank you for sharing your story. I have more questions for you because I think a lot of people are going to feel identified, but before we continue, the movements that you're mentioning, which are dyskinesias, are more common in women as well. And you're doing wonderful. I mean, this is a model of what a wonderful woman is. And she's following instructions, and she's doing her part, and she's doing very well. But I want to talk a little bit about also the treatments of other conditions that you may experience. And I would like Dr. Cielo to help me talk a little bit about urinary problems, bladder problems, incontinence, and how can we address those as women?
There's a lot of things that we can do, and it's way more common than you think. But again, we're not talking about it, right? So women do tend to have an issue with prolapse, urinary incontinence, especially after giving birth. And there are things as easy as pelvic floor physical therapy to help with, those prolapses, urinary incontinence. We also have a lot of providers now that are specializing in urogynecology. So essentially helping out with things like urge urinary incontinence, stress urinary incontinence, which usually comes from that weakened pelvic floor. Medications, which again are a little tricky in the setting of Parkinson's disease, but also things like Botox in the bladder nowadays are helping a lot of patients, and I think that's also very interesting because it's kind of like done every 3 months. You don't have to take a pill that may affect your symptoms of Parkinson's. We do know that also sexual dysfunction is more common in women with Parkinson's disease. And again, there's a lot of things that can be done about that. A lot of women do struggle with vaginal atrophy or vaginal dryness related to menopause, and that's such an easy fix. It just takes a cream that's very safe, and it's just a matter of having your provider help you out a little bit with those symptoms. So yeah, there's just a lot of options out there for those.
Yeah. And talking about the sexual dysfunction or decreased libido is a huge topic. And last week, I happened to have a patient coming to the clinic, and the husband asked me to step outside with him that he wanted to talk to me. And so the husband was concerned that she was dating someone, right? And nobody said. I was happy that he was open about it, right? Because he was in his own story, right? And he didn't know how Parkinson's can affect that as well. So by any means, she was dating anybody. this was part of her condition. And it's important for all of you that are out there right now, that I appreciate all the caregivers that are here, especially the men, to listen to this. Parkinson's can cause problems with sexual dysfunction and decreased libido. It's not your wife dating anybody else. It's not that your wife doesn't love you. But this is a topic that is a taboo. Nobody talks about it. And I was glad that he actually pulled me apart and asked me. And I said, you know what, I'm not going to tell your name, but I'm going to mention what you did, because I'm sure somebody in the audience is going to feel and is going to look and say like, good to know. So another thing besides Parkinson's, we have to be careful with the medication. So there are certain medications that we use for conditions that we treat in Parkinson's, like depression, that can cause as a side effect decreased libido as well. And Dr. Rodriguez, I mean, again, depression and anxiety are very prevalent in Parkinson's and are even more in women with Parkinson's. So if we try first therapy and, we need some medications, what is your approach on the medications and trying to avoid the ones that can cause these types of side effects with a woman in Parkinson's? What medications would you try if you need to go that route, and which ones would you like to avoid because of the side effects?
Yeah, not only that, but, again, one of the reasons why Dr. Ben has wanted me to be here is to destigmatize going to a psychiatrist. I'm a normal person, and not everyone leaves my office with medications the very first visit. We have to be very careful. We are cautious. We know these side effects can happen, but because anxiety and depression are so much more prevalent in women with Parkinson's, we do recommend therapy. That's always my first recommendation. And if it's appropriate, if there's no cognitive symptoms. But medications, unfortunately, can cause not only sexual side effects, but some of our serotonin reuptake inhibitors can make the tremors worse as well. Or it can cause weight gain, or it can cause a series of issues. So that's a conversation that I have selecting, depending on what's going on. Selecting the SSRIs are usually the first line of treatment. But again, those are the same exact medications that can cause sexual dysfunction, not in females, but in males as well. So there are some medications, but we have to be careful because of trying to not worsen any motor symptoms.
So, Amy, in your case, if you can share a little bit about how you feel when you heard the diagnosis, how you cope with that, and if there was any instance that you feel sad, how do you manage that? How do you pick up even your team? Do you go to your primary? Who do you go to tell or share how are you feeling, to know if that is due to the Parkinson's or to something else?
Well, don't follow my lead, because I have not gone to see a professional about anxiety and depression, which I know I should, because it's buried in me right now, and I work like hell every day to make sure it stays buried, and that is not healthy. I know that. So I think it's very important to recognize that stress, anxiety, depression, all of that needs to be addressed. Don't stick it in the back corner of your mind and think, I'm just not going to deal with it. Deal with it, and that's something that I need to do going forward. But yeah, my GP was initially telling me to do the same thing. I ignored it, but now, listening to all of you, I know that's going to be the first phone call I make when we leave today, is to set up an appointment for that, because it is so very much important to everyone.
Actually, and it can worsen the symptoms. And for me in particular, as the movement disorder specialist, if I have a patient coming that have Parkinson's and have worsening of the tremor or worsening of the cognition, the first thing that I'm going to say is, let's just make sure that we treat any other possible reason of this worsening, instead of just keeping increasing the medication that I'm giving them. So the first thing that I'm going to say is, make sure that we treat the depression, make sure that you're sleeping well, that you're not taking medications that are causing this, and then we'll increase the medicine if we have to. Now, talking about that, the medication that we use usually, or more commonly for Parkinson's, which is levodopa, it does, the medication actually becomes affected by the hormones as well. So one thing that needs to be discussed would be during perimenopause, during menopause, and actually before the menstrual period. Some patients feel worsening of their symptoms. I'm talking about women in particular, right? Because of these fluctuations in the hormones, and we need to adjust the dose of the levodopa. So take notes of that, and if you're one of them, that you feel that your symptoms are worse just before your menstrual period, or when you're in your menopause or perimenopause, it could be hormones, and your medications have to be adjusted. During pregnancy, we don't have that much data about pregnancy and Parkinson's, but in general, levodopa would be the medication that will continue, and we want to avoid amantadine. So all those patients that are on amantadine and that are planning to become pregnant, talk to your doctor, because that's one of the medicines that are going to be discontinued. Now, I want to talk a little bit about osteoporosis and the risk of falls. And the reason is that obviously as women, we have a higher risk of osteoporosis, and as Parkinson's patients, we have a higher risk of falls as well. So I think that it should be addressed by all of us in the panel. How would you manage if you have Parkinson's patients coming to your clinic? If that is something that, depending on the age group, you would consider and do the screening for osteoporosis, or do you refer them out, and what are the recommendations besides medicine that you would give them?
So to me, prevention is one of the most important things, right? And especially during perimenopause or menopause, a lot of women do not take their vitamin D. And most of them have low vitamin D levels, and you know, vitamin D works with your calcium to protect your bones. So again, a preventative measure for osteoporosis is make sure you're taking your vitamin D. And I'm not gonna ask you to go bathe in the sun, because again, more risk, I guess, but making sure you're taking your vitamin D supplements with enough calcium in your diet. Also, exercise, right? Women with, patients overall with Parkinson's disease have that fall risk, but it's important to perhaps join a program or do exercises that may be safe at home, because especially weight bearing, right? So we know that weight bearing exercises will increase muscle mass and also protect your bones. So even if it's 15 or 20 minutes a day where you grab some light weights, do some exercise, and this is for both for men and women, you're already decreasing your risk of osteoporosis. We do bone scans for patients. Usually some gynecologists will treat, a lot of primary care physicians or internal medicine will go ahead and give treatment for the osteoporosis, but I do think prevention is extremely important.
And I do agree completely. So starting now is very important, more than waiting until that happens. A hip fracture in Parkinson's is very different from a hip fracture in somebody that does not have Parkinson's. Dr. Rodriguez, what about sleep? So I think sleep is a big topic, and a big one of the questions that everybody asks me almost daily. And most of them would say, my psychiatrist is the one treating it, and this is what they're giving me. So tell me a little bit about the sleep. How do you approach the problem, if that's you or that's a sleep disorder specialist that we will refer the patient to?
So, and I can tie that into actually the osteoporosis and falls and everything as well, because anything that I can prescribe can increase, and especially as a geriatric psychiatrist, I have to be very cautious, because anything that makes you sleep, if you try to wake up in the middle of the night, that increases the risk of falls. If you have osteoporosis, that's, that can be complicating. But as far as actual sleep medications, my first recommendation is always trying to do therapy first, because in my opinion, and even in sleep medicine, someone who specializes in sleep medicine, they do not recommend long-term use of sleep aids. There's a lot of risks related to them, including cognitive decline, so it can start affecting your memory. It's the kind of medication that even causes amnesia, so forgetfulness. There's so many complications, so I usually try for people to try even self-directed cognitive behavioral therapy for insomnia. And if you go to a sleep specialist, that's going to be their first recommendation. So my first recommendation for sleep isn't necessarily medications, because it comes with a long list of risks that may now outweigh the benefit.
And that's a good approach. Now, obviously, I have to discuss the caveat that in Parkinson's, there is REM behavioral disorder that might need medicines for that, right? However, starting with a cognitive or behavioral therapy is a very important approach, and if needed, and some of you are going to be on medicines just because of a particular situation that happened in the condition. Amy.
Yes.
Were you afraid to hear the word Parkinson's?
Oh, absolutely. And I do want to go back to some of the other things you were discussing and just say thank you for not asking about my sex life, because I really didn't want to discuss that.
I was not going to. I went directly to the other question.
But when I heard the word Parkinson's, it kind of hit me like a ton of bricks. I was there on my own. My husband was not with me because he was out of town that week. And so I got the diagnosis, and I didn't tell him for a while because I just didn't know how to process that. I was dealing with my 89-year-old father who was in an assisted living place. I knew that if I told him, he would blame himself and say he gave it to me, which of course we know is not true. So I didn't tell him either. He did pass away 3 months after I was diagnosed. So after that, I just heard the word and from my initial diagnosis, and it just scared me. I mean, my self-esteem went downhill right away. I was thinking, okay, I've got to stop doing everything. I've got to just let this disease take over, and it's just going to do its thing, and there's nothing I can do about it. Now I know there's a lot we can do about it, and a lot of things we can do about it that don't involve medication. And so I think that's the path that I'm taking right now, is to pursue activities and things that'll make that diagnosis and hearing that word less scary.
I think that the fear is because of the unknown. Once you start listening and knowing that this is a chronic condition, right, that you don't die because of Parkinson's, but you die with Parkinson's. Mm-hmm. There are two things that increase mortality in Parkinson's, and one of them is not tremors. So nobody dies because of the tremor, but people can die because they fall. Or people can die because the food goes to the wrong pipe when they're eating, right? So aspiration pneumonia. So those two things, and I'm seeing a lot of my patients here, you know that, right? How many times I tell you that? So that's why you have to get strong, and that's why you have to do your exercise before things happen. So strengthen the muscles, do some therapy for balance, eat slowly, cut the food in small pieces, drink water. I mean, this seems to be like my day-to-day, like what I'm saying is what I repeat every day, but it's the truth, right? So don't be scared of Parkinson's. It's a chronic condition like diabetes. Now, diabetes, if you don't treat it, what's going to happen? Yeah, it's going to affect the kidneys, it's going to affect the heart, you're going to have a stroke. So Parkinson's, if you don't exercise, if you're not strong enough, you don't take your medicines, you're going to fall and you can die, yes.
Right.
So take control over that right now, and don't fear the word. Rather, do what you're doing. Get information from reliable sources. They're very, we do have a lot of information and sources that you guys can get from the Parkinson's Association of Central Florida. It's a very good place to get information from. We do have physical therapists out there that you can talk to them, okay? Nutritionists, sleep. The nutrition is very important, okay? We can be talking here forever, and I know we're short of time. But I just heads on the nutrition of what you eat, okay, and the type of diet and what things you should avoid. You should avoid things that are processed food, things that contain elevated, sugar. Like, for example, the cake that you like, it's not that you cannot have it, but it cannot be every day, right? So you don't have control over your genes. You don't have control over the hit to the head that you have in the past. You don't have control where you were born. If you were born near pesticides and herbicides and all that, but you do have control over the water intake. You do have control about your food. You have control of the exercise. And you have control of going out and socializing and being with other people. Because the people that isolate actually make all of these conditions worse. And it's not only Parkinson's, it's Alzheimer's and neurodegenerative conditions. So that's your part. And I know you're going to feel tired and you don't want to go. And there is a high prevalence of apathy, which is lack of motivation in Parkinson's, but you have to do it. You have to do it because I don't know, I have a lot of patients that would say, well, I'm 80. I don't know if you're going to live 20 more years. And do you want to live 20 years in the nursing facility?
Right.
So forget about the age number. We don't know how long we're going to last. Just do your part right now. And if you don't want to do it for you, do it for your loved ones. Because this condition affects their loved ones in a way that you don't even know. It affects their time. It affects the caregiver burnout and the amount of money and effort that they have to put in taking care of all of you is humongous. So not being, I know you did not choose the disease, but you can choose right now what to do. And again, for you and for your family that are just at your side, holding your hand in this path. That being said, I want to stop 1 second and ask Amy. Amy, you have Parkinson's and you're a caregiver as well. What the future is going to look, right? When do you decide then what's next? Do I have to move to an assisted living facility? Do I stay home? Who's going to take care of me? All those things, from my standpoint, have to be taken care right now, that you can participate in this instead of waiting for somebody else to make your decisions. Right. So what are your thoughts about that? What are you planning to do? What's the next step?
Well, the next step is I have to tell you that I don't have any children. Both my parents were only children. My husband is considerably older than me. I'm glad he's not here. But the next step, I think, is we've been looking at quietly, because my husband is one that doesn't want the world to know that we're looking to move, but we are looking at a CCRC. I don't know if you're familiar with those. They're continuing care retirement communities where you can progress through the stages you need as your condition progresses. I know that's coming, that my condition is going to progress, so needing care in the home, we just think that this might be the best route for us to go with a CCRC, so we're considering it. But then there are days when I say, I'm fine, I haven't fallen, I'm doing good, I'm doing all my exercise, we don't need to go there. But I just know that it's a big decision. Do you stay in your home, or do you go to an assisted living or a CCRC? It's personal, it's different for everyone. So you just have to talk to your family, work, with a professional who can tell you, and always trust your doctors. I mean, I find that when I talk to Dr. Bennis, and if I start talking about my sleep deprivation and all these things, you might want to bill Medicare for this, I don't know. But I think when I talk to her and I hear her advice, it really sinks in, it really makes me, realize that things are going to change, and they're going to change rapidly. I know that. I know it's coming. I'm not afraid of it anymore. And like she said, fear can be your enemy when you get a diagnosis such as this, because you can't just stop living your life and just freeze because you got that diagnosis. So I encourage everyone to talk to your family. If a move is in your best interest, do that. I don't know yet where we're going or what we're doing. It's all a process that we have to go through as the husband and wife. But we'll get there. And, I thank you for asking that, because it is an important decision for people to make.
We can do a summit out of Women's in Parkinson's, and I have to wrap up right now, thanking all of you for your attention, and the panel as well for being here with us, and especially Amy sharing her history. That's the most important person here in the panel, and you're hearing firsthand from somebody that is going through that. If you have one more thing to tell the audience, and I would like to wrap up after with Amy. if there was somebody in the panel, in the audience that that has fear or is having any symptoms, what should they do? What are the recommendations that you guys will give?
To me, and I think I've said it a couple times, is please talk to your doctor about your symptoms, especially when approaching menopause. It is so important to do so. So if you should take one takeaway from this is to schedule an appointment with your gynecologist, talk about menopause, talk about your changes, whether you want therapy or not, it's just important to talk about it.
Yeah, well, for myself and for my specialty, I would like everyone to know that, there's no reason why you shouldn't go see a psychiatrist or a psychologist. Medications can be very helpful. Therapy can be very helpful. We can help prevent things from progressing further. If that apathy that feels like you don't want to do anything turns into sadness, persistent sadness for more than 2 weeks, and you don't want to eat, you don't want to sleep, there's a whole series of things that can happen, and if there's a progression of the depression and we don't address it, the Parkinson's is probably also going to progress a little bit quicker. So I would just recommend that you even at least check in with your primary, and sometimes primary care also can address this kind of symptom, but anxiety and depression are two things that you don't want to just kind of let go. So that way, if you remember anything from me, it's that.
Let go of the stigma. Right?
Exactly.
Well, I think it's important to note that the physical symptoms can be addressed with medication, but it's the other symptoms, the mental symptoms, apathy, fear, and denial, I think, can take over if you let it early on when you get the diagnosis. So you have to make sure that you're working to free yourself from those thoughts. Talk to your doctor, talk to your neurologist, talk to your family. Don't be afraid. Don't keep it all internalized. If you have symptoms that you've never had before, for instance, my newest symptom is that I'm not able to sleep. I wake up at 2:30, 3:30 in the morning, and I can't get back to sleep. And then I need a 2-hour nap in the afternoon. Well, that's not how I want to live my life. So to address those things and not be afraid of them and not be in denial of what's going on in here as much as in your body and falling and that sort of thing. Yes, that's important. But it's also important to nurture your mind and to nurture the love that you feel from your friends and your family, and to trust your doctors. They know all of this. I mean, you can tell by today. I'm sure you've already learned things that you didn't know before you walked into the room this morning. I know I have. So just remember, everyone is here to support you. No one's going to judge you. I mean, women in particular, our self-esteem, our the way we look, we want to make sure we're out there in the community presenting ourselves in a certain way. And don't worry about it. Don't obsess with, oh my gosh, I'm moving a lot today. People are going to know. People understand. They want to support you. They want to help you. They're here for you. So just remember that. I had a hard time telling anyone. I had a hard time telling my coworkers. I was working at the time. But the support that I got from the community and from everyone else around me was incredible. And it's out there for you. The our Central Florida, the foundation here is just magnificent. You can get a lot of resource information there. But anyway, I could go on forever. I won't do that.
Your message is very powerful, and thank you, all of you. And to all of you, remember, Parkinson's is not gender neutral. So take that with you, repeat it tonight, and go to your doctor and advocate for yourself. Thank you.
Thank you.
Thank you.
Thank you. Thank you, ladies, for that powerful, insightful conversation. We need to embrace it, and it's not gender neutral, Dr. Lourdes Benes. Can we say happy birthday to Dr. Lourdes Benes? She celebrated her birthday last week. Thank you for all you do. Now, I'm excited about this next part. Who's ready to move their bodies? Yes? I think it's time for some movement. But before, Marie Caban from Say Yes Physical Therapy, by the way, they're helping my uncle. after he was diagnosed with Parkinson. So thank you so much for everything that you guys are doing for him. But before we do that, I want to encourage our caregivers. Go out there, go to the Recharge Lounge. It's a moment for you to relax. Maybe you can get a massage, take a breath. As soon as you walk out the doors, make that right and go in there and sign up for a massage before the day ends today, okay? All right, Marie, we're ready.
You. I'm gonna get one of the chairs that you guys are using so I don't present differently. Good morning, everyone. How's everybody feeling today? Good, good. A big applause to each of you and your caregivers for waking up early today, adjusting medications and everything else to be here today. Again, my name is Marie. I'm an occupational therapist. Say Yes Therapy here in Orlando. We are a rehabilitation clinic that specializes in therapy for Parkinson's disease. And before we get started, I just wanted to emphasize what has been said by the previous presenters over here. Exercise is a must for Parkinson's. And it comes free. You don't have to pay. You don't have to wait for an appointment to do it. So please take advantage of starting your exercise routine today. Stop by our table so you can gain information about the Parkinson's Foundation exercise fact sheet, which was provided this January with new recommendations. Okay, so with no further ado, if we can stagger our chairs, we're gonna start seated. So if my beautiful caregivers can stagger a little bit, pushing back on the chairs and leaving the other chairs forward so we can have a little bit of space in between each other. We're gonna start in a sitting position, and if we are able to, we're gonna bring ourselves to the edge of the chair. We're gonna make sure that our feet are at the distance of the legs of the chair. And we're gonna sit up nice and tall. We're gonna bring that belly button forward, shoulders back and down. And we're gonna get ready. Are you guys ready? Yes, here we go. So let's start with reaching up with our hands, like touching the sky. Let me see those fingers completely spread apart. Open apart those fingers. Close those hands and open for a count of 5, 4, 3, 2, 1. Bringing those hands down. Keep those thumbs by the side of your eyes. Beautiful. And we're gonna be like a butterfly. So we're gonna take those elbows and we're gonna bring them in. And we're gonna push them out, stretching that upper back. Let's go for 6. That's 1, 2, 3, 4, 5, and 6. Bring those hands forward, down to your lap, shrug those shoulders. So we go up and back 5 times. Let's go for 2, for 3, for 4, and for 5. Good job, everybody. We're moving down our body. Now we're gonna bring those hands forward. We're gonna work on those wrists. Again, we're gonna make like a big stop sign in front of us. We're gonna go wrist down and up. Down for 2, for 3, for 4, for 5. Bring those hands back in. And the next one, we're gonna go back. Forward, leaning forward. Nice. Make sure that you're feeling it on your groin, that lean forward. Go back in space. Big toe posture. Again, lean forward. Nice. Go back. 2 more times. Reach forward as far as you can. And back. Last one on this one. Let's move. Reaching forward and back. Wonderful. Let's bring a little bit of rotation to the lower back, okay?
So for this one, we're gonna open our hands out to the side. Wash your hands with your neighbor, so we don't want to be introduced in the wrong way. And I want you guys to reach one hand to the opposite side. So I'm going left to reach my right. Opening out big, reaching back again, and out. Again for 3, open, 4, open, and 5, open. Let's go 5 to the other side. We go for 5, open big, 4, 3, 2, 1. Bring hands down, and let's march it for a count of 10. Let's go. 1, 2, 3, 4, 5, 6. Big marching. 7, 8, 9, and 10. Feet down. Now we're gonna stretch, slowly stretch out as much as possible. Make sure that that ankle points with the toes forward and up. Up over here, and we go down and up as we're sitting. Point down and up, down and up, down and up, down and up. Let's do the same movement on the other leg for a count of 5. Pointing down and up, down and up, down and up, down and up. And our last one, if we're able to, we're gonna stand up, okay? So big lean forward, push down if needed. Nice standing. And let's use this music for a little bit of movement sideways, okay? So we're gonna go 2 steps to the side, 2 steps to the other side. Starting up to the right. Let's go. 1, 2 big steps. 1, 2 big steps. Again, 1, 2 big steps. Reach out with your hand if you are able to. Last set, we go 1, 2, 1, and 2. And here comes the most important one. Reach forward. Cross those hands and hold on your shoulder. Give yourself a big hug and say, I'm so proud that I came this morning over here. Good job, everybody. Thank you for joining us this morning. We hope that you continue learning new ways of improving your life with Parkinson's. Parkinson's is not a defining disease if we do not allow it. Okay, so big applause to you all, and thank you again for your time today.
Applause, guys, for Marie. How are we feeling? She's great, right? How are we feeling after that stretch? Are you guys ready for a little break? Go grab some refreshments, some fruits. Yes? Yes, okay, so let's do that. We're gonna take a small break, but I wanna encourage you guys again. Go visit the Recharge Lounge. Sign up, our caregivers, sign up for a massage. We will make sure the patient, your loved one, is taken care of. Go sign up for that massage, take a breath, and we'll see you in a few minutes.
Hello, hello. Okay, this definitely sounds much better. We're going to start shortly. This definitely sounds much better and clear. If we can have everyone come back so we can continue with our program. I hope you all enjoyed your break. Are you guys? Welcome back. Welcome back. We want to start with our program. Let's just give everyone else a couple of minutes to come back inside. How are you guys? Nice to see you again. You guys were here last year, right? Yes. I remember. I remember. Alrighty, are we all back in the room? I think we have a few chairs available, but I want to continue with our program. I decided to switch mics thanks to Terry. Terry, are you in here? Where's Terry? Terry came up and he goes, listen, I could barely hear you. I'm like, okay, we got to change that because I need you guys to hear me loud and clear. How was the break? Good? So I'm excited because they just informed me that you guys took advantage of the recharge lounge. That's great. They have all the massages already scheduled. So that's amazing. You guys are taking advantage of the recharge lounge, that moment where caregivers can just have a moment for themselves. Okay. So now, my friends, we shift gears because even in the face of challenges, there's still room for laughter. Please welcome Matthew Michael Moore. Is a performance artist, award-winning playwright, and Parkinson's disease activist who lives in Columbus, Ohio. He's also a patient diagnosed with PD in March 2019. Matthew has an MFA in acting from the George Washington University, and his acclaimed play about Parkinson's has toured all around the country. Do we have a change? Do we have a change?
it's not here. So, okay, so we're gonna go with our comedian soon, but before we do that, we're gonna move on to our next session, Parkinson's and memory, staying informed and staying empowered. This is live, guys.
Matthew, let me have you come here. Okay, yeah. Yes, let's have you. You want to go in the corner? Yeah, you can take that one.
Hi there. Can you hear me? This is working. Yeah. My name is Elliot James. I'm a nurse practitioner at a local neurology group. I have a modest nurse practitioner certification in movement disorders. Nothing like the fellowship training that Dr. Rodriguez, Dr. Benes have in movement disorders. I'm kind of saying that to repeat this term movement disorder a few times because, of course, Parkinson's is classified as a movement disorder. But in truth, we know as providers and Parkinson's patients know better than anybody, and it's been mentioned in previous presentations even today, how there are so many non-motor features of Parkinson's. And we're going to talk about one of those now, which is memory and cognition changes that occur. And in my experience, Parkinson's patients tend to be very well read. They read a lot. It's no small testament to that you're all here today, learning even more than you already probably have read about Parkinson's. And so because Parkinson's patients tend to be very well read, I find that a lot of people come in with a lot of fears because of things they've read that they feel may be happening or that they're concerned about happening in the near future or distant future. And one of those is they're all going to eventually read this term dementia. They're going to read this term Parkinson's dementia. And I think when we read that, a lot of times we just revert to this very stereotypical image of some family member we've known, some friend we've known, some person we've seen on TV who had a severe form of a dementia where eventually maybe they forgot the names of their children, forgot how to put their clothes on properly, those kinds of changes. But so we want to start with this. In most cases, they're thinking of more of an Alzheimer's dementia type of a picture a lot of times because that's the most common form of dementia. And so we want to start with this question of really what is Parkinson's dementia? What are the differences? What are the similarities between Parkinson's dementia and other types of dementia like Alzheimer's?
Okay, we can actually both talk about that. But if you don't mind, let me just say something really quickly about dementia, because as you said, it actually causes fear just because of the connotation of that word. And this is not even talking about Hispanics, because dementia in Hispanics is even, I mean, you are out of your mind. So, so as doctors, I think we should go ahead and explain this a little bit more so it would make sense. Dementia is a clinical term, and we need to call it how it is, period, okay? So we're not going to sugarcoat it. It is called dementia. Dementia is like Baskin-Robbins. So, you know, a place where you can get ice creams, right? And then dementia comes in different flavors. So you have vanilla, chocolate, strawberry, and all that. Alzheimer's is the most common cause of dementia after 65, but we do have, after 65 years, but we do have other types of dementia, vascular dementia, frontotemporal dementia, and we have also Parkinson's dementia. So Parkinson's dementia usually happens. First of all, it doesn't happen in everybody, but as we grow older and as the disease progresses, we have a higher chance. So when we talk about dementia, we're talking about some cognitive or memory problems that are actually causing that we need some assistance to complete activities of daily living. Now, that is different from Alzheimer's, and I'm going to have, if you want to talk about that, but to make the difference between one or the other. But we usually see Parkinson's, if we're going to see it, Parkinson's dementia is usually not at the beginning of the condition, but rather years into the diagnosis, and if it happens very early with the motor symptoms, when the diagnosis occur, then we do have to think about other possibilities like Lewy body. But the difference between Parkinson's, dementia, and Alzheimer's, if you wanna do that, or? Yes, I'll have you do it. Okay. Okay, so the difference between one or the other, in Alzheimer's, we have more memory problems, short-term memory difficulty, forgetting words and forgetting names, etc. In Parkinson's-related dementia or Parkinson's, even mild cognitive impairment, we have more problems with multitasking, with executive function, with attention, and visuospatial. So different from Alzheimer's, that is more forgetful. Alzheimer's, Parkinson's is more multitasking, speed of processing, and executive function as the presentation. Although down the road, they can start to become also forgetful. And some of the patients, unfortunately, have more than one condition as well.
So just a quick comment. So, going a little bit further. So in first place, not everybody with Parkinson's disease is going to develop dementia. And it is very interesting that, last year actually, there are these new way to define Parkinson's disease. And one of the things that we're gonna be working on in these definitions is that every person with Parkinson's disease looks different, right? Some people shake, some people do not shake. So there are certain things that will make some people more predisposed. But just like Dr. Bennett said, probably the most important thing that I tell people with Parkinson's disease is that don't multitask, right? Don't do what I try to do every morning where I'm trying to get ready, make breakfast, heat the milk for the coffee, so something is gonna break. It's usually the milk that will spill over, right? So you guys have to do one thing at a time whenever you're working with any particular task. But I don't want you guys to think that if you have Parkinson's disease and you have this Parkinson's disease dementia, you won't be able to recognize who your children are, you're gonna forget their names or anything, because that is not typically what we observe in people with Parkinson's disease.
Now, as patients, you should all ask your providers to do a baseline evaluation, because there's no way that we're gonna know later if you do have a problem if you didn't get a baseline. And I do the baseline evaluation, and we do it at the clinic, Dr. Rodriguez and myself, and it's more to give you a map so we can compare after, because you don't know what you don't know. You don't know that you have a problem. So it's up to us to be able to objectively compare. So going back to what I was saying before when I was doing the women's talk, advocate for yourself and ask for a baseline, because some of the things can change, and look to see what else you can be doing, because there are other reasons that can cause memory problems that are not necessarily Parkinson's themselves. So your doctor can do some workup to rule out other medical conditions that can cause similar problems, and keep working with your exercise and your cognitive exercise as well, learning, socializing, sleeping. Look at the medicines. That is not a side effect of the medication. Depression, anxiety, right? Blood pressure now, to see if there is something else that can be causing similar problems. So don't be afraid of that. Step up in the plate, get a baseline evaluation, look for reversible causes, and work on neuroplasticity to get better.
So in addition to some patients coming in with a lot of fear about these, I think sometimes you see the opposite, where some patients tend to downplay symptoms that they're noticing, and maybe more so males than females. Sometimes it seems like you see that they just kind of say, no, there's nothing wrong with me. This is what happens to everybody as we get older. Are there ways we can differentiate between normal age-related changes and what might be the beginning of Parkinson's-related cognitive changes?
Yes, so as we grow older, we may have some difficulty remembering short, things that just happened, but you're able to recall them if you go back and think really carefully. You're able to recall those. Now, red flags could be not able to recall. Other things would be like having difficulty performing activities that usually you're very good at. For example, if you're a carpenter, all of a sudden you don't know what to do with a hammer. And so it's not, a red flag would be you're good at something and now you have trouble, or you're not able, if it is short-term memory related, you're not able to recall after a little while. So it's okay to go to the refrigerator and don't remember what you were going, but then you look back and say, oh, it was the milk, and you go back and get it. That's normal. But another thing would be, for Parkinson's in particular, having difficulty multitasking. So people that were very good at keeping their records and doing their taxes and all that, and they usually do that in a couple of hours, and now they're in front of the computer 2 days, and they don't know, it doesn't make sense. They still are able to do it, but it's taking them longer. So that's another red flag that they're struggling. And again, for Parkinson's, more so with the speed of processing, and that usually improve when they take their medicines. So another thing that could be happening is that you're wearing off of the medication, and they feel slow the same way that they feel slow in their body, and they're shaking. Their brain takes longer to think. So somebody with a memory concern that improves when they take their medication is usually Parkinson's.
Yes, and Dr. Benes, I actually like that you mentioned probably the most important thing here, which is that there are some reversible causes of dementia. They're not that many, but they are there, and when we find them, they're very easy to fix. Probably the most common issue that we find in the clinic, at least when I see my patient, is I tell my patient, it's time to go back home. It's time to do your memory test before you go back home. And people don't want to do it, right? And there's no way for me to figure it out, right? And the one thing that I want you guys to remember is, if you do have a reversible cause of dementia, that sometimes all you might need is a vitamin B12 injection, or maybe some vitamin replacement, or sometimes, we have people that they come with some hormonal issues. So those are the things that we're looking for. And I wish this will be the most frequent one, right? Because they're easy to fix. But those that have it sometimes might not get the right treatment because they do not want to do the proper evaluation and the proper assessment. And sometimes it's just 10, 15 minutes extra in the clinic.
And they may be afraid. And they may be afraid to know, which, so I would be afraid not to know and not to do something for a symptom that can actually, could have potentially be improved or reversed, and ending up not being able to take care of myself. So rather than fear, you should be proactive on this, is what I think. Now, in Parkinson's, remember, depression and anxiety and sleep are huge. And all of those also can cause memory problems in all of us. It doesn't matter if you have Parkinson's or not. So going back, and he mentioned hormones, which is the other thing that's very important. So speak up about it, about the concerns, not only as a patient, sometimes the patient don't even recognize that, but as a caregiver. And don't see it as the caregiver is bothering because he's saying that and has it against you, but see it as the caregiver is trying to help and prevent something that is going to affect the whole family. Okay, and instead of fear, let's just be proactive and just advocate and get the test done and do what you can do and what is in your hands.
So I think if we can talk a moment about how to be proactive, what the best strategies are. Are there medications? Are there medical strategies on our side? Are there lifestyle improvement changes on the patient side? What are the most effective things that we can do to help specifically with Parkinson's cognitive changes over time? Can we slow it down? Can we improve cognition? What do we know about that?
So actually last year in 2025, and we're going to be speaking about this more a little bit later, there was a study that it is very interesting because technology in medicine is improving, and now one of the things that we can see is how we might be able to repopulate or help grow again some of these brain cells that are degenerating. So, about that, there was a study about people doing exercise, 45 minutes, 3 times per week. And after 6 months, what we learned from that group of people is that they were repopulating, they were having an increase of these neurons that, number one, affect Parkinson's disease, and number two, can affect memory at the same time. So it's just, listen, if we need to write in a prescription, exercise 3 times per week, at least 45 minutes, we're gonna start doing that because now we have some hard evidence, right? We used to see it in the people, but now we can see with these new technologies the changes happening in the brain. So don't take it lightly, right? We think that we have to pay a lot of money for something to work, when in fact, the solution might be as easy as let's just go around the community, let's do the right amount of exercise, and that might be able, that might be able to help us at least slow down the progression of these memory problems and the Parkinson's disease in itself.
Yeah, let me add something to this. It's getting out of the comfort zone, and we're all created to be in the comfort zone. So it's not easy to start doing it, but it doesn't have side effects. Now, there are no medications for memory in Parkinson's, for cognition in particular, that can slow the progression of the condition, of the memory in particular, of that symptom. That's different from Alzheimer's, that we do have a couple of drugs that are FDA approved, and they can actually, doesn't cure it, but can slow the progression. This is in research, and probably you're gonna be talking about that later today, about the medications that are in research and looking for disease-modifying therapy, but we don't have them as we speak right now. So it would be the data that we have and that actually show benefit, and we have good numbers about it, is exercise, and people have been doing or talking about this for the longest. But obviously, that doesn't have a medicine behind it, so it's up to us to speak about it, because otherwise, who's gonna pay for the commercial about exercise? Nobody, right? So that means that you have to, again, and share the word that we're saying. And I remember the AAN, the American Academy of Neurology, not long ago, the big news about this was about like how exercise can help with the memory, and the type of exercise as well, which is important. The cardiovascular that Dr. Rodriguez was talking about, and the strength is very important as well. So strength training needs to be added to this. Cognitive therapy or cognitive exercise, you guys, everybody have to be learning something new and wake up those areas of the brain that you're not using. So that means arts, that means music, that means learning a new language. So playing Sudoku just gets you to be the world's best Sudoku player, but doesn't help you in anything else. It's better than nothing, but if you really want to build connections, if you want to really go with the principle of neuroplasticity, you have to do something different. And one of them that is pretty nice and enjoyable would be dancing, that you're doing dual tasks. You're doing 2 things at the same time. So when you do dual tasks, have a lot of data about the benefit in cognition as well.
And to touch on real quick, because we're almost out of time, is that with cognitive changes, we sometimes do need support at some point, and we don't want to ignore the fact that Parkinson's affects our family members, our spouses, children. So what are some things maybe that the family or caregivers can do to help support brain health, to help support these patients, these Parkinson's patients, while, of course, also supporting themselves?
So, okay, there is 2 answers to that question. The answer that everybody wants to hear, and the answer that we hear in the trenches at the office. I'm gonna start with that one because that's the real word. So the nice one would be like, yeah, they follow what the spouse has said. That's not the truth. What the spouse has said, usually the patients will not do and will take it personal. She's making me, or he's making me eat this, or she wants me to drink water. She's forcing me, or he's forcing me to go to the gym. So unfortunately, and I want you to talk about your experience as well, but many of you are laughing because you know it's the truth. You know, it's the sad reality, and we see it not only in Parkinson's, I think we see it in all the conditions. And for that, what I do, though, is use other services, like physical therapy. So the bad one is the other one. It's not the spouse, because we don't want to create animosity anyways in the family, right? So getting physical therapy involved, occupational speech therapy, it could be a way to at least get it started. I usually sit down with a patient and go over the numbers. You guys are very intelligent people, and just because I say it, you're not going to do it. But if I show you the proof about those trials that Dr. Rodriguez was referring to, most of you would actually think it and say like, this maybe work, right? And the other thing that I recommend is if you can, pay for it. Because if you pay for it, you usually go not to just give the money, right? And those people that are enrolling a gym or are paying deductibles or whatever would be more compliant. Because the key here is not that you do it, is that you need to continue to do it. So consistency as well.
That's right. I saw a lot of views doing the, when she said about she's making me do this, like, it's right. That's probably one of the biggest complaints, and there's always a little bit of issues. Sometimes even in the patient's room, right? Like there's a little bit of animosity happening between husband and wife, But listen, I think that the one thing that I learned as a caregiver is they want the best for the patient, right? It's just, the way that we see that might be a little bit different, but the end result is we want really the best for the other people.
We're going to wrap this up then. I think then, especially with frightening prospects like the fact that we're going to have cognitive changes with Parkinson's, the important thing is mainly to speak up, talk to your providers. They have a lot of experience with this. This is very common, and they understand that. They've seen this a million times. And so the important thing is to bring it up, talk with them. They've got a lot to talk with you about with regards to that. Thank you, doctors.
Thank you all.
Thank you.
One more big round of applause. Thank you, Elliot, for moderating this session. So much information, right? I want to remind you all, there should be some note cards on your tables. If a question comes up during today's summit, write it down, because at the end of the program, we're going to have a Q&A where you can ask some of those questions to our doctors. Okay. Now we're gonna laugh, right? Now we're gonna laugh. Now it is my pleasure to introduce Matthew Michael Moore. He is a performance artist, award-winning playwright, and Parkinson's disease activist who lives in Columbus, Ohio. He's also a patient diagnosed with PD in March 2019. Matthew has an MFA in acting from George Washington University, and his acclaimed play about Parkinson's has toured all around the country with 50 performances in 10 different states, check you out, helping raise awareness about his common but rarely understood disease. Welcome, Matthew Moore, for stand-up stories and a song.
Thank you for being here. I feel very special. I was introduced twice. Thank you very much. I'm Matthew Moore. I was diagnosed with PD in 2019. My primary symptoms have been hair loss and weight gain. I'm kidding. I'm kidding. Hair loss is not a symptom of PD, although everything else is. I wrote a play about PD. You should watch it. I have a little flyer that'll lead you to a video of the play, if you'd like. I wrote a screenplay, so if someone wants to make a movie, you got $1 million laying around and you want to do something special with it, let me know. Because I've written some things, I often have people come up and ask me, what's next? What's next? And I say, without hesitation, Parkinson's the Musical. Oh yeah, with such songs as Shake, Rattle, and Roll. In the wee small hours of the morning, falling for you slowly. And my favorite of all the things I miss my mind the most. Which is why I have a cheat sheet up here, because even my memory is shaky as the rest of me. So, they say when the hardest part of stand-up comedy is standing up, you're in trouble. So I've had a lot of rigidity and stiffness that I'm working through. But speaking of standing up, I recently went to a minor league baseball game with a bunch of Parkies, about 30 of us. we were having a good time and enjoying ourselves, and somebody on the far side of the stadium started the wave. So the wave was coming around the stadium, came to our group of parkies, and of course we wanted to be part of the wave, so we stood up and we raised our arms and we missed it. we missed the, oh, my stool was delivered. I am special. Thank you very much. So I thought, well, I'm not going to take that sitting down. So I started to do the math, and I said, hey, when I say go, start standing up. So I kind of timed it out, and the wave was in the corner of the stadium. It was coming around. I said, go. All right, so we stood up, and we raised our arms, and this time we still missed it by like a mile. So some of us just stood there like this for the wave to go all the way around the stadium. Finally came to us, and we did the wave. So thank you, PD. Oh, man. There's some phrases that you typically use that don't apply so much when you have Parkinson's anymore. And one of those is hop in the shower. It's a phrase I used to say. I'm going to hop in the shower. I don't hop. I don't hop anymore. I don't even hop at the restaurant called IHOP. I'm certainly not going to hop in the most dangerous place in my entire home, which is the bathroom. I had one lady said that the only pole dancing she ever does is hanging from the grab bars in her shower. Throw on some clothes. There's another one. Throw on some clothes. I don't know what it is about changing clothes, but for me, it's a high-intensity interval training session. There's grunts, there's groans, there's loud noises, and that's just putting on one sock. Hurry up, we'll be late. So this is a phrase someone said to me, hurry up, we'll be late. And I said, no. I used to care about being late and would often, say, I'll be late. But that's not the way it is anymore, and so I say, you do you, I'll be me, I'll see you when I see you. So, you'll be glad to know I did something for you. I scoured the internet for the best jokes about Parkinson's. So here we go, with jokes from the internet. What do you call a cow with Parkinson's? Milkshake. That's right. Oh, milkshake. Now you'll all get this one. What do you call a brown cow with Parkinson's? A chocolate milkshake. What's the other thing you call a cow with Parkinson's? Beef jerky. All right. So, jokes from the internet. All right. I recently was writing some of the jokes for this, and I thought, I'm going to write smarter, not harder. So I thought, I've heard that AI can be a big help. And so I asked ChatGPT to write me 20 questions, 20 questions about Parkinson's. And it replied. I asked it for 20 jokes, 20 jokes about Parkinson's, and it replied and said that I was a monster. No, I'm not kidding. I'm quoting now its response to me. I was hurtful and insensitive. I was trivializing the lives of people with a devastating disease. A computer program took from me the moral high ground, my friends. Well, I knew enough about AI that I didn't want it to be mad at me, so I wrote an apology letter, sent it off, said, I'm sorry, and it replied, ironically, that it would think about it. And in the meantime, I should work on myself. I should be helpful, not hurtful. Oh, okay. So 2 ways I thought I could be helpful. I could work with tremor. Tremor used to be my big side effect until I got DBS surgery. So I know all about tremor. And I thought, well, let's see if we can just make these tremors something creative. Maybe we can even make money. So here we go with my list of what to do with your tremor. You can wave cars through. Come on. You can greet the queen. You can dry Polaroid pictures. Oh, look how skinny I was. You can beat some eggs, you can deal some cards, you can be in a Taylor Swift video called Shake It Off. You can hit the fire button on a video game real fast. You can burp the baby. Ugh. You can reel in the big fish. You can paint like Jackson Pollock. Only the smart people are getting that joke. And you can throw candy at the parade. So there you go. Things to do with your tremor and make money. The second thing I thought I could do was come up with a way to diagnose Parkinson's that was kind of like a real way, a boots on the ground way to diagnose Parkinson's. Forget all the fancy medical mumbo jumbo. So here we go. 14 ways to know if you have Parkinson's. If no one ever asks you to bring them a can of soda from the fridge, you might have Parkinson's. If you've stopped feeding the grandkids because your food airplane has too much turbulence, pull up, you might have Parkinson's. Here's a harsh one. If it takes more time to button your shirt than it does to wash, dry, and fold it, ouch. If it takes 3 or more butt bounces to get up off the couch, you might have Parkinson's. If you're the one making the bride and groom kiss all the time at the reception, ding, 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 you might have Parkinson's. If you've ever lost a battle with a twisty tie and a loaf of bread, you might have Parkinson's. If your pill box doesn't fit into your carry-on luggage because it's the same size as your carry-on luggage, you might have Parkinson's. If you take more naps than your cat, you might have Parkinson's. If you kick the bad guy in the shins only to wake up from your dream and realize you kicked your partner in the shins, you might have Parkinson's. If you've ever thought brain surgery sounds like a good idea, you might have Parkinson's. If your pharmacist is invited to your annual family picnic, you might have Parkinson's. And here's my favorite. If you get more done before 7 a.m. than most people do all day because you've been up since 2:30, you might have Parkinson's. Can I read a little story for all of us? This is stand-up stories in a song. So this is a story. It's a brain test. So like Sudoku or crossword puzzles, that kind of stuff. A brain test. I want you to pick out all the puns in this story. We're going to have a little pun fun. Oh, boy. Okay. So here we go. This is called colonoscopy. That's the kind of humor I'm doing. Okay. Being a man who has reached a certain level of maturity, I recently discovered a new innovation for getting a colonoscopy, which might be better called a colonoscopy if you think about it. I just got done telling you that I was a man of a certain level of maturity. Let's say 4th grade. Anyway, at my annual checkup, my doctor told me it was time yet again for a colonoscopy so we could get down to the bottom of my health issues. But, he said, our schedule is pretty backed up, and there's a new in-home version of the procedure that's a smooth move. And I said, you want to do this colonoscopy in my kitchen? No. He explained that they mail a kit to your house so you could go number 2 in a little bucket, seal it up, and send it off to UPS. I tried to be funny. Take it to UPS. What is this, the United Poo Service now? No, he said, please stop making colonoscopies the butt of all my jokes. Sorry, I said, and I told him I really appreciated what he did in the end. Anyway, my doctor ordered the kit for me right on the spot, and I started thinking, I don't really want my neighbors to see this colonoscopy kit on my front porch all day, so I asked him, is there any way they can deliver it in the rear? Yeah, he said, that's how they usually do it. So I got the kit, and I started reading the instructions, which seemed really complicated. I didn't want to get pooped out because I thought, it'd be a real bummer to have to do this all over again. Finally, I made it to UPS, only to see that there was a line. Oh, crap, I said under my breath. I took a number and I sheepishly waited around. Oh, number 2, the guy yelled. Right here, I said. He put it on the little conveyor belt and sent it on its way. I don't know why, but I waved goodbye as it rolled along. As I waved, though, I saw another box just like mine, and another box just like mine. And I started to think, how many colonoscopies are people taking these days? And how well are they strapped into this truck? Because God forbid, were that truck to get rear-ended, well, that would be quite a show. There's one more. The end. Oh, don't clap for that. So how did I first know that I was a PWP? Well, I was cheering on the Buckeye football team because I'm from Ohio. And 2 minutes into halftime, I'm still cheering. And I couldn't stop cheering. So my partner at the time, who was less of a care partner, more of a care commando, said, we are getting an appointment with a neurologist for you this week. Now, everybody in this room knows you don't get an appointment with a neurologist in a week, but you don't have a care commando. So ultimately, I saw 3 neurologists. I underwent a battery of tests. I had the neuropsych exam. I had an MRI, a PET scan, a DAT scan, the SAT, the ACT, a bar exam, a mammogram. All the data came back, and no, I was not pregnant. Yes, I did have Parkinson's, but no, I wouldn't make a very good lawyer. So we found out some interesting things. The neuropsych exam, I don't know if how many of you have taken this thing, but this is a doozy. It's 3 hours long. It tests all your mental capacities. And one part of this test is naming as many words as you can in a minute that start with the same letter. Anybody know what I'm talking about? Yeah. So the person administering the test to me said, let's use the letter F. I'm like, well, I know one. And this is a true story. This is a true story. It's just so happened that in college, I had memorized a story called The Parable in F, which tells the story of a prodigal son using almost entirely words that start with F, about 200 of them. You can see that I didn't get out much in college, but that's what I was doing. So I immediately thought, hey, I'll use the words of the story and I'll just deliver it one word at a time, not make it sound like a story. That's what, so good Matthew's like, no, tell her to give you a different letter. Bad Matthew's like, you're a peawad, man, a person with a disability. Use the story. That's what I did. So I started saying letters that start with F. I just one word after another, and we get to the end of a minute, and she goes, wow, you know a lot of words that start with F. And I said, fortunately. And to answer the question burning in your mind, no, I never did tell her. And yes, I'm going to tell you that story right now. Feeling footloose and frisky, a feather-brained fella forced his fond father to fork over his farthings. He flew far to foreign fields and frittered his fortune, feasting fabulously with faithless friends. But facing famine and fleeced by his fellows in folly, he found himself a feed flinger in a filthy farmyard. He feigned he would have filled his frame with foraged food from the fodder fragments. Ah, phooey! My father's flunkies fare far fancier. The frazzled fugitive fumed feverishly, facing facts. Well, filled with foreboding, he fled forthwith to his father. He fell at his father's feet and cried, Father, I have flunked and fruitlessly forfeited family favor. Well, the faithful father figure, forestalling further flinching, frantically flagged the flunkies to fetch forth the finest fatlings and fix a feast. Well, the fault-finding frater, that's the brother. The fault-finding frater frowned on the fickle forgiveness of the faithful father, and his fury flashed but fuming was futile. For the faithful father figure said forcefully, "What forbids certain festivities? The fugitive is found. Unfurl the flags with flair. Let fun and frolic freely flow. Former failures are forgotten, and forgiveness forms the foundation for future fortune." I'm finally finished. So if you're going to have the neuropsych exam, there you go. There's a lot of F words and not a single bad one. Oh, jokes from the internet. Are you ready? What's the best thing about having Parkinson's? You don't have to pay for Botox. Is it possible to stutter in sign language? Yes, if you have Parkinson's. What disease do you have if you're really good at making cocktails, but really bad at stealing tambourines? Parkinson's. All right, two more. I told my friend my dad's a glass half full kind of guy. He said, "Oh, he's an optimist." No, he's got Parkinson's. And why is Alzheimer's better than Parkinson's? Because it's no big deal to forget a beer, but it's tragic to spill one. There you go. Just from the internet. Okay. On a more serious note, I think one of the difficulties of Parkinson's is that there's so many unanswered questions. And these aren't funny, they're just true. When did I get it? I don't know. They say that you've had it for a decade at the point of your first symptoms. Where did I get it? I don't know. I've lived in 21 different places as an adult person. Where did I get it? I don't know. How did I get it? I don't know. I do have a theory, though, that it was one too many birthday parties in the ball pit at Chuck E. Cheese. Because who knows what kind of toxins are down there. Why did I get it? Well, there's a doozy. I don't know. Maybe for times just like this. Why did I get it? And what does the future hold? I don't know. But I know the one who does know, and that makes a difference. In the meantime, let's find a cure, shall we? All right, so I have a little song, stand-up stories in a song. I write Parkinson's parodies sometimes. So you've heard of the song, "If I Were a Rich Man." Well, all of us out here are hoping for the end or the disappearance of Parkinson's. So if I had a good brain, from the tremor on the roof. That one deserved a groan. If I had a good brain, da-da-dee-a-dee-a-dig-a-dee-a-dee-a-dum. If I had the dopamine I need, I wouldn't have this Parkinson's. I wouldn't have a tremor. Yada-dee-a-dee-a-dig-a-dee-a-dee-a-dum. If I had a really great brain, I'd a diddle-deedle-diddle man. I'd sleep all night and not have dreams where I punch my wife and kick her in the shins. I'd go all day and not take a single pill. I would play pickleball and move really fast and not say, "Stop, I gotta go, number 2. That would be the greatest thing of all. The most important neuro doc would come examine me. She would say, "What happened? I don't quite understand. I know you had Parkinson's. You really had Parkinson's. But now you don't. I don't know why. You must be healed by God on high. You have the dopamine. You've got all the dopamine you need." And I'd walk right out of her office and skip my exercise that day and live my life like I'm neurotypical. If I had a good brain, yada-dee-a-dee-a-dig-a-dig-a-dee-a-dee-a-dum. If I had the dopamine I need, I wouldn't have this Parkinson's. I wouldn't have a tremor. Yada dee dee digga digga dee dee dum. Lord, who made the lion and the lamb, you decreed I should be what I am. But would it spoil some vast eternal plan if I had a really great brain? All right, one last thing. I usually cry. I'll try not to. The most common acronym for a person with Parkinson's is PWP, right? I'm a PWP. Well, I don't know about you, but I don't want to be defined by an acronym. I know you don't. So, I may be a PWP, a person with Parkinson's, but first and foremost, I am a person with patience. I'm a person with pep and personality. I'm a person with perseverance, piety, playfulness, and practicality. I may be a person with pasta, pizza, popcorn, and pie, but I'm a person with plans and purpose. I'm a person with power. And I'm a person with what may be the hardest of them all, peace. So that's the kind of PWP I want to be. And that's the kind of PWP you want to be. And Parkinson's, it's never going to change that. Thank you.
Thank you. Thank you so much, Matthew, for bringing joy and laughter. It was definitely a refreshing moment. We have to laugh a little, right? That was very special. All right, who's hungry? We're hungry, right? So we're going to take a break for lunch. But before you get up from your seats, we're going to go around to collect the passports. You see these passports right here? Do you guys all have one? I need you guys to put your names on it. We're going to collect these because we are going to use these for the raffle that we're going to have later on, okay? So I hope you all enjoy your lunch. We'll see you here because there's more sessions and more information for you all.
Every 6 minutes, someone is diagnosed with Parkinson's disease, making it the fastest growing neurological disorder in the world. So if you don't know someone with Parkinson's now, chances are you soon will.
I remember like it was just yesterday, in the prime of my life, when reading of all things a Michael J. Fox piece. I noticed a tremor in my finger, my ring finger. I said, no, not me. Fast forward 4 second opinions later, and it was confirmed. I had PD, Parkinson's disease.
It might be your dad, your mom, your son, your daughter, your spouse, your friend. And the faces of Parkinson's might not be the faces you'd expect.
Oh, the day was awful. I told my wife, you don't have to come. The first appointment's nothing. They just kind of talk to you and order tests, and you come back in 6 weeks. I was not prepared at all for a diagnosis that day, and it was a kind of scary feeling.
A lot of these younger patients were diagnosed with multiple sclerosis, or you probably had a stroke or something like that. But now, people are raising an eyebrow like, listen, it can be Parkinson's disease. There's more awareness that this could happen in younger people.
Diagnosis is not the end. It's just the beginning of the fight.
At first I was mad at God and the world, but soon enough I'd rebound and want to fight back. Enter Parkinson's Association of Central Florida. They were the missing piece. And the message that they had for me was, you are not alone. We are here.
The Parkinson Association of Central Florida was born out of this desire to do something, anything, to make a difference in our local community.
We were getting very tired of taking our loved ones to Gainesville for treatment. So we kind of put our heads together and came up with the brilliant idea of getting movement disorder specialists here. We didn't have any.
The local focus is everything for us, because we are addressing a need with our own neighbors, our own community. It's our fight.
PACF was built firmly on the principle of doing things right here, right now, for our friends and family in Central Florida.
We're not giving the money away to just any organization. We're supporting what helps your husband or your wife.
So now that we have better resources, we see that people have a better quality of life for a longer period. I'm going to give you an example. Now we have groups that do rehabilitation therapy, that they dedicate their practices to people with Parkinson's disease. That was an unknown. That was not happening before.
Finding the Parkinson's Association of Central Florida has certainly helped. It's amazing. It has good resources and a lot of good information. It's just critical. There's so much to learn about this disease.
PACF funds support groups, Parkinson-specific exercise programs, educational events, community resource events, caregiver support, grant funding.
The community it surprises me how much is in that community. I mean, it blows me away. The resources and the positiveness and the caring of people is really incredible.
PACF has grown into one of the largest local Parkinson's nonprofits in the country. Our Walk for Parkinson every April is the single largest Parkinson-centered gathering in Florida every year. In PACF's lifetime, we've raised more than $2 million. That's money we're turning around and putting right back into our Central Florida Parkinson's community.
My heart just goes boom whenever I see this many people that we are actually helping.
Simply put, PACF is here to improve the quality of life for Central Floridians impacted by this horrible disease.
Now I have 2 teams I cheer for, Parkinson's Association and the Orlando Magic.
We are here for you.
We are here to fight for you.
We are here to help you.
We are here
because community is everything.
We are here, and you are not alone.
For more information on PACF and the resources featured in this video, go to parkinsoncf.org.
Okay. We are back. We're going to continue with our program because we're just a little bit behind. How was lunch? Yes? That's amazing. I want to thank those that have approached me, that I've been able to hear your stories. Thank you so much for the words of encouragement, the ones that have given me some advice to share with my family, with my dad, who has now become a caregiver for my uncle, who has Parkinson's disease. Thank you, and thank you again for sharing your stories, for being here at this summit. I had someone approach me, and she goes, I have my brother who doesn't live here. He doesn't live in the state of Florida, who was diagnosed with Parkinson's disease. And she said, he doesn't speak any English, and I don't know how I can help him. And I told her, you're doing the right thing, just being here, right? So I think let's give each other a big round of applause, because we're doing the right thing, just being here and just getting all this information, valuable information that we can share with our loved ones. All right, at this moment, I would like for all of you to please direct your attention to the screen for this video, Living with Parkinson's Stories of Strength.
Hello, I'm here today with
Matthew Moore,
from
Columbus, Ohio.
Wonderful. And Matthew, what does your brain need for today?
Encouragement.
Encouragement. All right, let's.
Every step forward, no matter how small, is meaningful. I like that.
Yes, it's a wonderful message. And how would you apply that to your life today?
Well, I'm about to do a little stand-up comedy. Just a few minutes. So that's going to be a little step forward. I've never performed for this many people.
No, and
but I have the encouragement to do so.
Wonderful, and we're lucky to have you here. And what would you say to those patients as well as you for that encouragement every day?
Well, to do things you like to do. Don't let the barrier of Parkinson's get in your way.
Agreed.
Yeah.
Agreed. That's a wonderful insight. We're here with
Alex Lane from Supernus Pharmaceuticals.
Wonderful. And what does your brain need for today?
We'll go with a brain fact.
Brain fact, wonderful.
Social interaction activates complex brain networks and is one of the most powerful ways to support cognitive health.
Wonderful. And how do you practice that, or how do you socialize in order to help yourself?
I'm in a book club, so we have planned girls' nights because everyone's schedule gets so busy. So just trying to make time for friends.
Yeah.
And I call my friends on my way to and from work.
Oh, that's wonderful. I'm here with
Scott.
And where are you from, Scott?
I am from AB.
Okay. And what does your brain need today?
My brain needs today Voices of PD.
Voices of PD, all right.
It says acceptance doesn't mean resignation. It means understanding reality and deciding to move forward. Michael J. Fox.
Okay, and how does that apply to our patients today here at the summit?
I think it really means that there's hope and that there's opportunity. And them by being here really gives them the opportunity to learn and educate themselves, and to also provide that hope that there's something out there for them.
Yeah, of course. And how do you provide that as well on your part?
So on my part, I have a product that helps patients have a continuous, complete control of their Parkinson's symptoms, and it's called ViaLev.
No, wonderful. And I'm excited to hear more about ViaLev, okay?
Okay.
You're not alone in this fight. We saw that amazing recap of what this summit has been all about this morning, and I can tell you I've been doing this for 3 years. I think this is my third year, if I'm not mistaken, and it just gets bigger and bigger every year. So once again, we want to thank you for being here. We want to thank our sponsors. We want to thank Neurology One for organizing this event, for all the organizations that make this event possible. Now we move on to our next session. We turn to the future of Parkinson's care, a future shaped by progress, research, and hope. After everything we've heard today, this is where we look forward. Please join me in welcoming Dr. Ramon Rodriguez, a fellowship-trained movement disorder neurologist and medical director at Neurology One, dedicated to advancing Parkinson's care through research, innovation, and patient-centered treatment.
All right, thank you. All right, thank you for coming. Much appreciated. I will be having a presentation about the latest research in Parkinson's disease, and I'm going to help you understand why you are doing it, so you have a better idea about how this is going to apply to you. But before I get there, I have to make sure that I say thank you to some people here, and the first people I'm going to say thank you to are the staff at Neurology One that are here today. They're actually volunteers as well during this event, so I'm going to ask them to stand up and say hi. So I have Lily. There you go. You all know Lily. Maru. Maru, say hi. Emmanuel. Is Emmanuel here? Should be outside. Yeah, Emmanuel is the one that everybody thinks he's my son. And listen, I love the guy, and I wouldn't, I'll take him as my son. It's not a problem. Victor. Yeah, so Victor has been the one recording, and then Danielle. Danielle is the young lady that was speaking and interviewing people. So once again, much appreciated. Our nurse practitioners, we have two of them here. Maria Torres. Maria, they're probably outside. Oh, there you go. Maria is right there. And then we have Yifei Zhao. So Yifei is right there. She's the last member that joined us. And then, two very important people for Dr. Benes and myself. So my wife, Jennifer, who's right here. And Eduardo, who already, Eduardo is the guy. Eduardo is like a MacGyver, right? He'll figure out anything, he will make it happen. But they are, they have been the brains, the people that keep the clinic running and making these events and so on. So we're much appreciative of them. So once again, the title of the talk is Stronger Than Yesterday, Progress and Promise in Parkinson's disease. And we're seeing some changes and some new things happening in Parkinson's disease that I'm very impressed, because I didn't know if in my life as a physician I was going to see some of the things really happening, because we've been speaking about them, but the truth is that we're knocking on the doors to some phenomenal therapies. And a lot of the things that I'm going to be speaking about are going to be research related. Be aware of that. So people that have access to this are people that only volunteer to these research studies. Just going to talk about them. Some of them are actually already available, and I'm going to explain to you what this is, and I will bring some answers about some of the previous presentations that we have done. So let's go ahead and get going. So the first thing that is happening in Parkinson's disease is that we're finding better ways to make the diagnosis of this condition. And the reason is this. For the past 100 plus years, we have been diagnosing Parkinson's disease based on clinical grounds. So I look at the patient, walk here, walk there. I have many people coming to the clinic and they tell me, I just saw a doctor, he saw me walking back and forth, and he said that I had Parkinson's disease. But it's sometimes very difficult for you to come to terms with the diagnosis when you don't have more workup than that. What is really going on with me at that point? Is there something else that is happening? And one of the biggest changes that is happening in Parkinson's disease is that there's going to be some testing that we're going to be performing in order to make this diagnosis more accurate, right? So just like Dr. Morgan mentioned earlier, remember that Parkinson's disease begins many years before the diagnosis happens, right? There is a day where destiny said, you're going to have Parkinson's disease, and at that point, what is really happening is that there is a protein that is in the brain that just changes the form. And those forms make these clumps that we call them the Lewy bodies, right? I'm not speaking about Lewy body disease. They're just called the Lewy bodies. That's how we see them in the pathology. And when this happens, there is an oxidation process, right? And this is what causes some of the damage typically associated with Parkinson's disease. And the name of that protein is alpha-synuclein, all right? That's a scientific word that you guys need to take home. And that is the pathological hallmark for people with Parkinson's disease. And this is the protein that begins, this abnormal protein begins the process of abnormal movement and abnormal thinking, okay? And there is a new classification that is showing up. We call it the synergy classification. This is 2025. You know, we're still trying to come to terms with this because for so many years we have been looking at people, have them do the finger taps, hand movements, you know, twist your hands and so on. But now we're trying to get better evidence about the diagnosis. And what this means is that we're going to be doing the first part of the diagnosis, just like what Dr. Morgan mentioned earlier, there's going to be a skin biopsy. And what we discover is that this abnormal protein in the brain that is called alpha-synuclein, there is a research group that found that they are able to find this in the skin. So what is going to happen is, in many patients, we're going to be doing a skin biopsy that goes right above the ankle, so just about right here, right above the knee, and then in the back, 3 different places. And we do 3 places so we can make a better diagnosis. That makes the process a lot more accurate. And when we do that and the test comes back positive, what we're really seeing is alpha-synuclein. So their normal protein that is being deposited in the brain, now we're seeing it in the skin, right? So this is a big change because now we can make this. But 5 years ago, I used to tell people, 5 years ago, 3 years ago, I used to tell people, the only way for me to make sure if you have this abnormal protein from Parkinson's in your brain is to look at a big slice of the brain under the microscope, right? So we just don't do that, right? You know, we typically do that when people pass away. But now we can see this in progress as it is happening. Number 2 is we're going to be looking into the neurodegeneration. And just like Dr. Morgan mentioned, you know, he asked how many of you had a DAT scan? And the DAT scan is that test that you get a contrast, and that contrast does a job in a part of the brain called the basal ganglia, and we begin to see some changes, right? So where Parkinson's disease is trying to get is trying to be able to measure where the disease is. So let me explain to you what that means, right? Right now, when we do this testing, the result is positive or negative. It's just yes or a no. But one of the challenges that we have in people with Parkinson's is, if yes, how much? So let me translate this, right? If you have diabetes and you check your blood sugar today and it is 500, and tomorrow morning you check it again and it is now 200, tomorrow you will be better than today, right? 200 is better, 500 is really bad. So you're able to measure this. We're trying to find out ways where we can measure the density of these cells in people's brain to give us an idea, okay? And I'm going to tell you how that is looking and why this is important, okay? But I do believe that one of the most important aspects of this diagnosis is this. Earlier, we did mention that if you go into a room full of people with Parkinson's disease, everybody seems to look a little bit different. Dr. Morgan said that only about 70 to 75% of the people with Parkinson's have tremors. What that means is that 30% do not shake, right? And many people, they tell me, doctor, it cannot be Parkinson's because I am not shaking. And what happened is that there is a type of Parkinson's that we call the slow and stiff type of Parkinson's disease, the akinetic rigid type of Parkinson's disease. Those people don't have any tremors. And one of the things that we have learned is that the progression of Parkinson's disease in those people that do not have tremors seems to be different from the progression of Parkinson's disease of people with tremors, okay? And then where the dementia is coming from. So this is what is going to happen. People are going to have a biopsy that is going to show us this alpha-synuclein. We can do the DAT scan, which is going to show us the neurodegeneration, right? How this is looking in the brain. But then we're going to start to subtype Parkinson's disease after that, okay? And how we're going to be doing that, at this point, one of the things that we're going to be looking is into genetics, okay? We're going to be looking into the genes. And you know what? If any of you ever wonder, you know, how my genes look in regards to Parkinson's disease, 20 years ago, getting a genetic test for Parkinson's was next to impossible, okay? Now, you go to the internet, you can go to the Parkinson's Foundations, and they'll send you a kit. You spit on that kit that they'll send you, send it back, and they'll send you at least the 7 most common genes, if you have them or not. Free. My favorite 4-letter word that begins with an F. Free, okay? So these things are changing. They're becoming a lot more accessible, right? So this is the synergy, right? And when we're looking at the genes, we have some genes like LRRK2. 30% of the people with Parkinson's disease actually have this LRRK2 phenotype, which is how we call it, right? And the important thing is that we do have some medicines now that seems to be able to slow down Parkinson's in people that have that particular pattern. So the testing is going on, and this is going to help us try to understand better if we can actually modify the progression of Parkinson's disease, because the idea is this. Before we're able to find the cure, which we're really working really hard, or we're trying to support the people that are working hard and trying to find a cure for Parkinson's, while we get there, if we slow this down, and you're able to live a life where you never see the day where you need to, you need to be using a wheelchair or it's hindering you, right, in terms of your functionality, I think that is going to be a big, big change, okay? So, some people test positive for early Parkinson changes, but they don't have symptoms yet. This is very important because now what is going to happen is so once again, I'm referring back to Dr. Morgan because I want you guys to understand why this is important. If you are a person that has the vivid dreams, if you are the person that has the changes in the sense of smell and constipation, we always say that if you have those 3 things, you will have Parkinson's disease at some point, very likely, right? Now with the skin biopsy, I might be able to see this, confirm the diagnosis even before you start having symptoms. And if we have a medicine that we already know that can slow down Parkinson's disease, that will be the time to begin that medication. That way we can protect your brain, so we have more cells protected for a longer period of time. So this is why this technology is very important. These changes in the brain seems to be very subtle. We have to make decisions about the timing. I'm going to tell you that we have a list of people in our clinic, they are our patients, and they went to have a sleep study. And in the sleep study, it turned out that the doctor said, oh, you have REM behavior disorder. That was the wording, right? REM, sleep behavior disorder. People go home and they look into the internet, and the truth is that if you have REM behavior disorder and you put that, you will read about that relationship with Parkinson's disease. And then people will keep reading, and then if they see like I'm having the constipation, I'm having the changes in the sense of smell, they end up in our clinic. So we have a group of people in our clinic that have all those 3 symptoms, and we actually do the biopsy, and the biopsy comes back positive. So what that is telling me is that they are developing Parkinson's disease. They just don't have the symptoms yet in terms of the tremors, the stiffness, and the slowness. And we need those patients because if we want to slow down Parkinson's, we really would like to begin very early, right? And the reason is we want to protect some of these brain cells. So how this looks, right? So the skin biopsy test is called the SIN1 test. That's the brand name of the testing. Once again, we do a small skin biopsy. It's something very small. I had that photo there and just realized that it looks like it broke when I was doing the biopsy, but no, it does. That's the shape of the tool that we use it. But we just take a small piece of skin and that's the one that we send to the lab. Takes about 4 to 6 weeks for it to come back. And then I get a yes or a no about Parkinson's disease, whether you have alpha-synuclein or not. The one thing that we're learning now is that some areas, like the back of the neck, seems to be the one that correlates the most with Parkinson's disease itself. Remember, Parkinson's disease, it is not the only condition that is positive for this alpha-synuclein. But what that will do is, from a range of diagnoses, it's going to bring us into about 3 of them: Parkinson's disease, multiple system atrophy, or Lewy body disease. And from there, we can differentiate one condition from the other. But this is how these biopsies might be able to help us a lot, okay? 3 different places, the lower leg, the thigh, and the neck. And then the area of the neck is the one that seems to be better correlated with Parkinson's disease. Other testing that we have is we have a lumbar puncture as well available with a technology called the seed amplification assay. Now, this test is very sensitive as well. It's a really good test, but I'm going to tell you something. People do not want to have a lumbar puncture, a spinal tap, just to be able to get this fluid. So where Parkinson's disease research is moving is they are moving from the spinal fluid into the blood. So we're hoping that anytime soon we're going to be having a test that we're just going to be doing a blood test, and it's going to show us whether we have this alpha-synuclein protein in our bodies that correlates with the diagnosis of Parkinson's disease. So this is a big, big change, because now if you go to have those sleep studies or whatever it is, or you have the vivid dreams, you have the problems with constipation and the sense of smell, and now you have a blood test where this will come positive, now you have a good idea about what is happening, and it will help us address the condition easier in a patient. Even if that means only, let's try to exercise earlier, and let's get serious on the exercise situation, all right? So the spinal fluid test is very accurate. Obviously, the lumbar puncture, we're moving into the blood-based biomarker. We actually have something like this in Alzheimer's disease. So we have a blood test as well that seems to be very accurate to tell us whether a person is developing Alzheimer's disease. Now we're moving into the Parkinson's disease world, okay? Let's talk about neuroimaging, and a little bit earlier we spoke about the DAT scan, and the DAT scan is a nuclear medicine test that helps us watch some differences. So going back to Dr. Morgan's presentation, he showed some pictures, and he was talking about the coma shape, right? Some people with Parkinson's disease tends to lose that particular coma shape, and one side is typically more affected than the other side. When we see it like that, that correlates a lot with Parkinson's disease. But the other thing that we're seeing is that now we have this PET scan that seems to show some brain inflammation. We call it microglial activation. And this seems to be one of the predictors for those people that will have Parkinson's disease dementia. A little bit earlier, we were sitting here, and we said that 30 to 40% of the people with Parkinson's are the ones that are going to develop this Parkinson's disease dementia. Obviously, this kind of testing is going to help us help predict better who's going to be that particular person for us to understand what is going on with this condition. And obviously, if there seems to be an element of inflammation here, you remember that Dr. Morgan mentioned that medications called NSAIDs, like ibuprofen, naproxen, so might be protective for these conditions. It might be related to this sort of inflammation that we see in the brain. Okay, so this is very interesting. This is very new. This is, we are actually dealing with the issue of how we are going to be implementing this in our practice in a way that is reasonable. All right? Now, let's talk about new therapies that are coming in Parkinson's disease. And Dr. Morgan mentioned the word tavapadone. Tavapadone is a medication that we actually did the clinical trials in our clinic. And this is a new type of dopamine agonist. So what this medication is going to do is it is going to stimulate dopamine receptors. However, the medications that we have right now, which are dopamine agonists, they are good, but the problem is that they might be associated with certain side effects, compulsive behaviors, memory problems. Some people have issues with changes in the blood pressure. What tavapadone does is that it stimulates different receptors, and we believe that by stimulating these different receptors, we can improve the symptoms of Parkinson's disease while avoiding those side effects. And the good thing of these medications is that they're taken once per day, right? Once per day. My projection is that this is going to be available, I think this is going to be available by September of this year, okay? So in early October, there is a big Movement Disorders Congress. And I think that the company that has this is trying to get this approved by the time of that Congress so they can do the formal rollout on this. So it has already been submitted to the FDA. I have to say it's a powerful drug. I was part of the investigators in the clinical trials. And you guys know, for those of you that have been in a clinical trial, you know that some people take the real medicine, some people take the placebo. But in this particular trial, after the end of that phase, there was a second phase where everybody took the medicine. So I knew what they were taking and the patients knew what they were taking. So those patients were doing, you know, from what I saw, they were doing fairly well. So I'm quite encouraged. I'm hopeful that this is going to be a great addition to the treatments that we have available right now. One of the challenges that we have right now with Parkinson is that these pills last a short time. So you take it and then it goes away, you take it, it goes away, you take it, it goes away. If we have something that lasts all day long, so it should be able to make life a little bit more predictable. Another therapy that is new that came recently in 2025 is that subcutaneous apomorphine infusion. So this is not research, this is available, all right? And this is a therapy where people connect a small cannula, typically in the abdomen. They can put it in the thighs or other parts of the body. And they have a small pump. And that pump is going to administer medicine. So this will be a better option for people having more fluctuations in the way that they respond to the medicine. And I think this is a great alternative, right? And there are multiple pumps already available in the market. The one attraction of this pump, so the connection to the skin is the same for all of them. But the pump size is a little bit different. This particular pump uses a medication. The active ingredient is called apomorphine. And that apomorphine is a medication. It's a dopamine agonist that is very powerful. And the idea is to administer this medication for 16 hours a day. So you wake up at 7 a.m., you put it on, and you should be covered until 11 p.m., for example. At that point, you take it out, go to bed, and the next day, you begin your regular day. And then, obviously, during the night, you probably need to take regular carbidopa, levodopa before you go to bed. And the pump is a little bit smaller. I don't know if somebody has one of these pumps that might be willing to show it. Or maybe, you know, one of the, because this is already approved, I think that one of the vendors outside, they have the pump there, okay? The second pump is Vyalev. And Vyalev is a subcutaneous infusion of something that we call foscarbidopa, foslevodopa. Sounds very similar to carbidopa, levodopa, right? So the pump has foscarbidopa, foslevodopa, but the moment that it gets into the skin, it becomes carbidopa, levodopa. And the idea is that that way you can put a lot of the medication and it stays stable in the vials, but once it goes into the body, it becomes carbidopa, levodopa. The difference of this pump is that this pump is designed to run 24 hours a day. So the previous one, the Vyalev pump, yes, the Vyalev pump. And once again, you know, we have the Vyalev people outside, so you can go ahead and take a look at it. And this one is running 24 hours a day. So you put it at 7 a.m., and some people sometimes run the pump for 3 days in a row. So they don't even have to change it. They just have to put more medicine, but they use the same cannula and the same equipment at that point. Yeah. So she has a question. She asked me, but you can put this yourself? Yes, the idea is to put it yourself. Some of you know that in 2014, 2015, we had a medicine called Duopa, and that's the one that required the small tube in the stomach, right? But people didn't like the tube in the stomach. That drug is still available. I think it's a phenomenal drug myself. But the issue of the tube in the stomach has been a challenge. However, for people that are having more challenges, now we have something that requires no surgery. People do this at home. And the great thing is that, you know, the drug companies, they have a system where they send a nurse to your house. They will train you how to put this on, how to work with it, and so on. And I have to say that 9 of every 10 patients that try this, they do it very well. Okay? So it's a great therapy. Now, we have, because we do the research in our clinic, we have some long-term data that we have access to, and what it's showing is that over time, people seem to be doing even better and better. So initially, they have about 3 hours where they find that this medication is working better for them per day. Now it's going to about 4.5 hours that the medication is working better compared to before taking it. So this is a significant improvement compared to the oral medications that we have available. Okay? This is a great therapy. And listen, I'll tell you that this will be a therapy, you know, this is not a last resort therapy, okay? We have some patients that they are approaching the time where they need DBS, but they don't want to have DBS. They don't want the brain surgery, so this will be a great therapy, okay? Or we have some people that they want to wait for stem cell studies. So this will be a therapy that will not disqualify them from being in a stem cell study when they happen, okay? Once you have a DBS, typically, that will preclude you, will not let you be a good candidate for the stem cell studies, which we're going to talk about them because they're happening very soon, okay? Another great thing that came in 2025 is adaptive deep brain stimulation. So in last year's symposium, I spoke about this, that this was coming. So now it is here. So let me tell you how this is different from the previous DBS therapy. The DBS world is changing really fast. So now these devices, these DBS electrodes, they are not only giving you the benefit that you're looking for, but they're actually sensing what is happening in the brain. So when you need more of this power of the DBS, let's just put it that way, the system self-adjusts and gives you more power. And when you need less, it self-adjusts to give you less. So now the system has some sort of control over itself. So I think that is a phenomenal idea because I do believe that this kind of technology has the potential to reduce the adverse events that people will have with this kind of procedures, okay? On top of that, the batteries last longer. We used to have to change it every 3 to 5 years, right, John, for DBS? Now these devices, they last 10, 15 years. There's even a device that in the US is approved for 15 years, but in Europe, the same device is approved for 25 years, that battery. So back in the day, we had to change these batteries every 3 to 5 years. Now these batteries might not even have to be changed, you know, for the rest of your life. So this is, once again, one of the biggest advances. The other thing is focus ultrasound. I'm going to spend a minute here because this is probably one of the most common questions. Doctor, am I a candidate for this focus ultrasound? And basically, this is an incisionless brain surgery. So this is brain surgery without having to open the head. So for that, you can tell that it's very sexy, something that many people will be very agreeable to. And in my impression, it is mostly a good therapy for people having a lot of tremors, right? And the medications are not helping. And we might think about doing deep brain stimulation, and that patient says, doctor, I don't want DBS, like I don't want anybody to do an open brain surgery for me. So MR focused ultrasound, that's how we call it, might be a reasonable option. I'm going to be honest with you, it's not my first option, but it is an option. And especially for those that, number one, they don't want to have the wiring of the DBS, which I do believe should be the first option. It's the best therapy there is. But for those that don't want it, or those that are not good candidates to have a surgery where they will need the anesthesia and all that, so this might be a reasonable option. But I want you to think that it is going to be mainly useful for the severity of the tremor, all right? If we make the tremor goes away and everything else stays the same, that's what you're going to get. So sometimes people have trouble walking. Sometimes people have trouble with fatigue or, I don't know, depression. Doing this is not going to fix that. This is going to work mostly on the tremors, okay? There might be some other applications for this, but at this time, this is, I think, that what we're doing 95% of the times, okay? Ah, there you go. Yeah, she said she's thinking about these therapies already. So let's talk about other newer therapies, and I want you to pay attention to this because this is very interesting, okay? And we are, you know, in our clinic, we're part of these programs. So I mentioned earlier that there was a day where Destiny said, you're going to have Parkinson's disease, and this abnormal protein was deposited in the brain, and the name is what? Alpha-synuclein, right? So there is some research going on with this medication called prasinezumab. That's a long name. And by the way, I forgot to tell you this, but we created a syllabus of all this that we're going to be putting on our website, and you will have access to it to download it. And it's going to explain all these things, okay? So this prasinezumab is a medication that, in a nutshell, this is what it's going to do, okay? So I mentioned you that people with Parkinson's have this abnormal protein in the brain called alpha-synuclein. So the prasinezumab is a medication that is going to come and it's going to get inside the brain and it's going to find the alpha-synuclein and it's going to latch into it, okay? And then what is going to happen at that point is something very similar to when I was a kid. Let me tell you, I used to go to Walmart. I'm sorry, not Walmart. I used to go to Kmart. And Kmart had something called the blue light special. You guys remember that? And I remember being at Kmart and the blue light special, like they will turn the light on, they will ring the bell, and people will run there. They didn't know what was on sale, but everybody went there, right? Let's find it. So that's what is going to happen. Alpha-synuclein, prasinezumab, when this latches there, this microglia will come and it's going to engulf the whole thing and try to remove it. So it's a medication to try to remove this abnormal protein from the brain, okay? Now, be aware that there was a study done, and the study showed that there might have been some direction to make it better. That's why Dr. Morgan said earlier that there's going to be a study lasting for 6 years. There was a direction that it might do better, but it didn't show the benefit. But when they look at the data, they said, but look at this group of people. These are the ones that seems to show some benefit. You remember earlier, I told you that we're going to be subgrouping people now in Parkinson's disease. So the Paraíso trial, the Paraíso study, is available right now. This is going on right now, and they are looking for people to volunteer that might be willing to volunteer. They have to meet the criteria for the study, and they will be able to get these medications at no cost. So it's part of the study. Now, be aware, some people is going to get the real medication, some people will get a placebo. And there's nothing I can do about it. Nobody can do anything about it because the computer is going to flip the coin and it's going to choose what you're going to get. Now, I always say that there's no other way to find out if the medication works. This is what the Big Brother requires to approve something like this, and this is what we have to do, right? So I always, I learned this from Dr. Benes. If you do nothing, you're automatically in the placebo part, right? Because you're not taking anything. So at least you will get the opportunity to get this medication. Looking into stem cells, right? So we have been speaking about stem cells for a long time, but finally this stuff is already up and running and is available. And there are two approaches going on right now. The first one is this bendaneprocel, okay? Bendaneprocel, basically what we're doing here is we're using donor embryonic stem cells that are turning to dopamine-producing neurons. So these are cells coming from another place. They are put inside your body, and they go into the brain, and they're going to make dopamine-producing neurons. So what they're trying to do is, over time, people have been losing these dopamine-producing cells. Can we replenish that? Okay? The second one is we're going to take cells from the people, the patient, and we're going to transform them into dopamine-producing cells and put them back. That study has taken a long time. We have been speaking about this, and the issue is it has been difficult to find laboratories that will be able to make these cells. Remember, they have to do this in Florida, they have to do this in California, they have to do this in New York, and everybody has to be doing the same thing. And when you're doing a clinical trial, you want to make sure that everybody's doing it correctly. And that has been the challenge. You know, can all these places have the same technology? But guess what? It is up and running. This is happening right now. I think this is a great trial. The third one that is moving into, this is very interesting, is this. We have these cells in our brain that they're waiting to be told what they are going to do. For those of you that knows a little bit of science, they are called pluripotent cells, right? So we have a medication that we're going to be putting in the brain, and this medication is going to go to those cells, and it's going to tell them, you start making dopamine and connect and replace those dopamine neurons, right? So this is all, listen, this is all crazy because I never thought that as much as we were talking about this, that we were going to see this stuff here, but this is up and running right now, okay? So be aware of these things, and they're available. Go to the internet. We're going to be putting some information about this in our website. For those of you that might be interested in knowing more, there's going to be available right there, okay? Couple other things that I think worth noting, and this was published last year. So Dr. Morgan was speaking, where is this Parkinson coming from? You know, and Matt was speaking about where is this Parkinson's, why this is happening to me, right? So we're trying to figure out where Parkinson's is coming from. And one of the things that they talk about was about higher risk in people drinking water from a well, farmers, and people dealing with chemicals, right? But what this study is telling us is that you don't have to be the farmer to have this risk. And basically what they publish is the results of the risk of developing Parkinson's disease if you live nearby a golf course. And what the study showed was this. If you live within 1 mile, there's about 125% higher risk of developing Parkinson's disease. That's a lot, right? If you live nearby a golf course, there is a much higher risk to develop Parkinson's disease. And I'm going to tell you that in my clinic, I have a lot of people that work in golf courses that they have Parkinson's disease. I have a lot of jet fuel mechanics in my practice, right? I have people that work at the airport in the tarmac, loading and unloading luggage and doing stuff. It's just too many, right? There has to be something going on, just like in Vietnam, right? You know, when we see all those veterans exposed to Agent Orange, that seems to be the cause. So something is happening. So now, like, the risk is coming to us. So we don't have to go to the farm to be exposed to this. So, you know, it's a testament to how important it is to drink clean water, make sure that, you know, we're trying to minimize pesticides and fertilizers and you name it, all these kind of things, right? The study also showed that for every mile that you move away from the golf course, the risk decreases by 9%. So just look into this, right? You know, this is worth thinking about. There are some gut changes in Parkinson's disease, people with Parkinson's disease, and we always talk about the leaky gut, okay? So somebody earlier, Pam, actually, she mentioned about she's taking probiotics, right? So I'm in the band believing that probiotics might play a role in Parkinson's disease because we believe that if this gut lining is normal, that might help decrease or at least throwing more salt to the wound in people with Parkinson's disease. So there might be something there worth looking into it. I'm not going to go any deeper in the interest of time, but it's going to be in the syllabus that I mentioned to you, okay? Lifestyle management. This is something that I spoke about a little bit earlier. And this is a study that shows that people that were doing high intensity exercise, and let me tell you how this looked. What they were doing is cycling, indoor cycling 3 times per week, and spinning, there you go. And then when they were riding the bike, it had to be at least at 75 RPM. Does that ring the bell? People that do spinning? Yeah, so 75 RPM for 45 minutes, 3 times per week. And what this shows is that this type of exercise may increase this dopamine transporter activity, okay? And basically what this is showing us is that there seems to be some changes in the brain consistent with positive changes in people with Parkinson's disease. That's what we call neuroplasticity, okay? A word about non-motor symptoms, something worth noting because we spoke about this a little bit earlier. There is a medication called rivastigmine that we use for people with memory problems. I think that it is worth to try it. Some of these medicines come oral. It comes as a patch. I like the patch better because it's better tolerated. It's called rivastigmine. The brand name is Exelon. Okay? It can help the memory in people with mild to moderate dementia, in people with Parkinson's disease. For people having hallucinations, and Matt, he spoke in his section about hallucinations, and John, so there is a medication called pimavanserin, which is the established treatment for people with Parkinson's disease hallucinations, right? We call it Parkinson's disease psychosis. It's the only medication approved by the FDA. There are some other medicines that we use off-label. All these medicines, they have something called a black box warning. So every time you get prescribed this, we have to tell you about this black box warning, and we'll get into details if you ever find yourself in that situation, what this really means. But from my perspective, if the patient was my own family member, I will try these medicines. Okay, I think that they're worth using them, and that's why we recommend them. And then autonomic dysfunction, sleep and pain, those are big challenges. There's non-drug treatment. This is where physical therapy, eating more fiber, trying to have good sleep habits. Please do not take the cell phone or the iPad to bed with you. Take a real book with a light, but try to avoid anything that will disrupt your sleep, right? Sleeping is going to be very important in people with Parkinson's. And with this, I'm just going to cut it here because I want to make sure that we have some time for questions. And this is coming in a little bit, the Q&A. But we have a section now. Are we going to the Q&A now, Giselle, or a little bit later? We're going to hear from Heather. All right, yeah, so we have Heather, please come. We'll have a time for those to do the Q&A in a little bit, okay?
Thank you so much, Dr. Rodriguez. We've definitely had some significant advances. And I want to remind you again, like Dr. Rodriguez said, you guys have those note cards on your table. Make sure to jot down your questions. We will try to address them towards the end of the program. Okay, it is my pleasure now. We move to an important topic for every patient and family planning for the future. Please join me in welcoming Heather Kirsten from the Elder Law Center of Kirsten and Fuller. Thank you.
Good afternoon. Thank you so much for having me, and thank you to Neurology One for hosting this amazing event. I have a soft spot in my heart for Neurology One because they've helped my father improve his quality of life significantly. Can't hear me? They can't hear me. Is that better? No? Okay. Thank you. Sorry about that. Is that better? Yes. So I was saying that Neurology One has a soft spot in my heart because they've helped my father improve his quality of life significantly. So I want to thank them again. Today we're going to talk about the importance of durable power of attorneys with superpowers, Medicaid benefits that pay for home care, and also life care planning. So our firm, we have 17 employees. We're downtown Orlando on Robinson. We have 5 attorneys. 3 of us are board certified in elder law. So the importance of planning. I speak at a lot of public speaking to help people understand that there's urgency in planning when you've been diagnosed with a progressive disease. A lot of people wait to do their financial planning and their estate planning, and a lot of families come to me when it's too late because the person cannot execute documents. So as the disease progresses, there may come a time where time will run out for doing the legal work. So we want to ensure that you get your estate planning in order so that your wishes are honored and you can choose the people you want to make decisions for you, and also to share what your wishes are with them so that they honor your wishes, not their own. The durable power of attorney, from our perspective, is the most important document as you progress in any progressive disease, because that's the document that allows someone to make financial decisions for you. A lot of times people say, well, my spouse can do it. Your spouse can only control assets that are also in your spouse's name, and inevitably there's assets that are not in your spouse's name, such as qualified funds like 401ks or IRAs. So we want to be sure that a durable power of attorney is in place. Also that you would have a successor agent named after your spouse. A lot of times spouses get sick at the same time, or the caregiver gets sick from the time that they've been caregiving, so we want to have a successor named. In Florida, we have what are called superpowers under the durable power of attorney. And that change went into effect as of October 1st, 2011. So you'll want to write down that date, October 1st, 2011. The superpowers are powers given to your power of attorney that must be initialed. So if you go home and look at your durable power of attorney and you don't see sections that are initialed, it's more probable than not that you want to update that document. If you have a durable power of attorney from another state and you now are a Florida resident, it would behoove you to update your durable power of attorney so it's consistent with Florida law so that the banking institutions will honor it. So why are the superpowers important? Many of the superpowers are the powers we need to protect assets to access public benefits. So in Florida, we can do what's called Medicaid crisis planning, where we can protect all your assets, especially if you have a spouse, and we can still access public benefits to help pay for your care. And that would be care in the home, in assisted living, or nursing home. Everyone wants to stay home, and as elder law attorneys, we do everything in our power to help you stay home. And this is part of the process to give caregivers respite care so that there's other people that are being paid to help provide care in the home. So some examples of the superpowers would be different planning techniques we use for Medicaid planning, and also creating specific trusts that are often necessary for Medicaid planning and Medicaid eligibility. So one of the programs I want to talk about is called the Home and Community-Based Services, also known as HCBS. This is a Medicaid program in Florida that is through a waiver program. And this program is the benefit that can help pay for home care in the home. So although your spouse or child might be a caregiver for you, this would allow you to bring in separate caregivers to provide respite care, or possibly pay your child through the Medicaid program to provide the care they're already providing. So this program does have a waiting list. You do have to get on the waiting list and then go through the interview. There's an eligibility criteria, and then the services provided would be things like assistance with personal care, homemaker services, adult daycare, respite care, and case management. So we see this make a big difference for individuals that want to stay home, because even with a long-term care policy, it may have a deadline. It may only be valid for 3 years. the biggest thing we see is we want to support the caregivers because the caregiving job is so stressful, and statistics show that it's common for the caregiver, unfortunately, to pass away before the person they're caring for because of the stress, and also that they put their own needs and their own medical care on the back burner while they're caring for someone. So this program can help you stay at home as long as possible. And then if you're approved for this program under Medicaid, you could then transition to an assisted living through the Medicaid program or to the nursing home under Medicaid. There's a misconception that if you have assets, you cannot qualify for Medicaid. There are requirements for qualifying, but in Florida, we have many planning techniques that can be done in the crisis to protect the assets for the spouse or even for the children to ensure you get the public benefits necessary to pay for your care. So life care planning is a new service that our firm started offering last March. My background was as an associate geriatric care manager before I went to law school. So I used to be in the field assisting families with the aging process and care issues. And that's what inspired me to become an elder law attorney, because I saw how much an elder law attorney helped one of our families with the Medicaid planning. It really transformed this couple's life. The husband needed a nursing home, and the wife was terrified that she was going to be completely impoverished by the cost of care. And elder law attorneys can get involved and ensure that the person receives the care they need while protecting the assets for the spouse. So life care planning is a benefit. We started this last March. It's been going very well. When you hire us for estate planning or Medicaid planning, and if you have any care needs, in our firm, we assign an elder care coordinator to your case. And that person is available to you and your family members at any time during office hours to call as much as you want for any questions regarding care. So it's set up that we would do an assessment of you. We would help with placement in a facility if necessary, help secure caregivers that we've worked with long-term to bring into the home. We can advocate in regards to which types of doctors you might need and provide you recommendations on that, provide you recommendations for contractors if you have issues in your home. So it's really an advocacy and coordination program. I've used it for my own parents recently. Our elder care coordinator's been helping my mom and dad because my mom and dad are both having significant health issues. So our elder care coordinator has spent many hours with my parents just this past week, helping them get all their doctor's appointments coordinated, getting a lot of loose ends taken care of because I'm not available during the day. So that's made a significant difference for them. They actually love the elder care coordinator and ask me about her all the time. So this is a really important piece of our practice because it for me brings in the personal aspect of coordinating care and advocacy in addition to just the legal work. So the life care planning, you're going to get the personal tailored plan, you're going to get the care coordination and advocacy. And for the families, you're going to get peace of mind, especially if you do not have children that live locally. So we have a lot of elders that don't have family members here helping them, and this is a nice bridge to make sure that their needs are being met. So what is an elder care coordinator? They're an individual that has specific skills and knowledge to help clients and their families ensure that they can attain the highest quality of life possible. There's a lot of benefits out there, and there's a lot of services that people don't know about. Navigating the long-term care continuum is extremely difficult. People really don't understand how Medicare works and how Medicaid works, so it's very confusing when you're in that system and trying to understand what's covered and what's not covered. So that's where we can be the link to guide you through that process. So the elder care coordinator is going to be there to answer any questions, provide support, help clients and families identify care problems, assist them with identifying and arranging the proper care, whether it be in home, in an assisted living, or in a nursing home, and help with coordinating transfers and transportation, guiding the client and family through this maze of long-term care issues, calling for and attending care meetings at facilities, and overall advocating for the best interest of the client. So the goals for life care planning, there's 3 principal goals. That would be, we help you make sure that you or your loved one receives the necessary long-term care. Under our healthcare system, the only pay source for custodial care is Medicaid. So Medicare is going to pay for your rehab and your doctor's visits and hospitalization, but Medicare does not pay for home care. So when you need assistance with activities of daily living, like bathing, dressing, toileting, transferring, Medicare is not the pay source for that. And I'm going to give you some scary numbers. The cost of a nursing home care right now in Central Florida is about $15,000 a month. The cost of assisted living in Central Florida ranges between $4,500 to about $8,500 a month. And the cost for home care is running between $32 to $40 an hour. So as you can imagine, those are very frightening numbers. What we want you to know and leave here today knowing is that we can help. So if you come to us and we look at your overall estate planning, we look at your finances, we can always come up with a strategy where we can get you some help. And the sooner you do it, the better. I have a lot of people that wait, and the children always say, I thought I had more time. So I would urge you to address this issue urgently. I would urge you to make it a priority to get your estate planning updated, to meet with an elder law attorney. The distinction of an elder law attorney from an estate planning attorney is an estate planning attorney is simply going to create your will, trust, durable power of attorney to avoid probate, to make sure that the beneficiaries you want to receive your assets receive them. Our plan, we also do that estate planning, but we're looking at it from the eye of disability and long-term care. So we're making the plan is how are we going to walk you through this continuum of care as independently as possible with the most public benefits as possible to make your money last as long as possible. So the life care planning is just a great piece of our new program that's going to make such a difference for the families and give you peace of mind. The summary and key takeaways, please, please, please look at your durable power attorneys when you get home. I can't stress this enough. I mean, a durable power of attorney in our office costs $475. If you don't have a good durable power of attorney and you lose capacity, you have to go to the court and get guardianship. And you want to avoid that at all costs. We want to make sure that your durable power of attorney has superpowers. We want to look at, are you eligible or could you become eligible for the home and community-based program that helps pay for home care? And life care planning. Can we get involved now to help make this process as smooth as possible and to have your quality of life be the best it can be as you go through this process? So thank you so much for your attention today. Thank you for attending the event, and it's been my pleasure to talk to you.
Thank you, Heather. Okay, guys, we're getting close to the end. We're going to have one last break, so take advantage, go move around, mingle, and once we get back, we have some great items that we're going to be raffling, so get ready for that, okay? I'll see you soon. All right. All right, guys. Let's see who our lucky winners are today. We have a lot of great items that we're going to be raffling, and then we're going to get ready for the final part of our summit, the Q&A with our experts. All right, so let's see. So how are we going to do this? Okay. A ver, who's our winner? Okay. Let's see. All right. Michelle Mazer. Is she still here? Michelle Mazer? Okay, we'll put it aside. Okay, next. Okay. Next, okay. All right, guys. Bob Driscoll. I'm sorry. Oh, the pressure was on, but you're going home with an item. He told me earlier, he goes, I was here last year and I won something. So I'm like, okay. Yay! Here you go. Enjoy your new Echo Spot. Okay, let's see who's next. Let's see. Okay. Robert Brock. No? Robert Brock? Brock? No? Okay. Next, okay, let's give an opportunity to someone who is here. Okay. Ready? Tom Pete. Tom Pete. Oh, there he comes. Okay. Thank you. All right. Okay. Here you go. Enjoy. Watch your step. Of course. Socorro McFarland. Socorro McFarland. Okay. So we'll hold it for her. Okay, can you hold this for Socorro? Hold that right there. You can hold that one for her. All right. Okay, let's do this again. I know. There's so many. I'm glad everyone participated. Lori Lori. Yay. Did I mess up your last name? Lori. There you go. Congrats, Lori. Enjoy your Echo. All right. Okay. Wow, look at all of that. Carol Blackburn. Carol Blackburn. No? Okay. Son muchas. There's too many of them. All right. Shells Rothenberger. Cheryl's Rothenberger. Anyone? No? I think they probably left. No? Okay. All right. Come on, help me out here. Okay. Fur Louis or Phil? PH. Yes? Okay. Can you give that to him? Is this you right here? Yeah, that's you. There you go. Enjoy. Thank you.
Thank you.
You okay? Okay. Georgia Parkinson. Yay! Congrats. Can you give that to her? Deja que la niña pase. Mi amor, so he doesn't have to walk over here. All right. We have a few items left. All right. McFarland. Didn't I call Mac? Oh. Okay. Oh, yeah, his wife. His wife. We're holding his wife, right? Yeah, I think his wife has one. And now we have, let me see, this one didn't have a name. Barbara Boston. Barbara Boston. Oh, right here. And I really love these echo spots. They're great because you can put any reminders, you take your medication, if you have to go exercise, they're wonderful. How many do we have? ¿Ya le dieron ahí? Okay. 5. Okay, let's do. I love this. All right. Okay. Dixie Van Dyke. Where's Dixie? No? Oh. Okay. There you go. Congrats. Okay. Hay que guardarle la cosa que está en el baño, ¿no? I don't know. Is that? Oh, Yolanda. Yolanda Medina. Ah, Yolanda. Thank you. Do we have one more? Perfect. Okay, great. All right. Okay, let's see. All right, Iris Rodriguez. There you go. The orchid right here. Una orquídea. Here you go. It's beautiful. Can you? Okay. Yes. Is that all? Oh, we have more. You see, guys, there's more goodies. Okay. Let me put this down. All right. This is a one-night stay at the Aloft Lake Nona. This, you see? Okay. Bill Parker. Bill Parker, you're staying one night at this beautiful hotel. Here you go. Can you give that to him, my dear? Here. Míralo. All right. Okay. 2 more. All right. Digantes Nain. I don't know. Woohoo! Dinner for 2 at Tempo and Grace. There you go. That's the restaurant that they have here in this hotel. Congrats. Okay, our last one is coming up. All right, let's see. Let's make this good. Okay. Lugo, Glenda Lee. You guys are staying for one night at this beautiful hotel. Can you give that to them? All right, congrats. Enjoy your night here. Okay. All right, guys. Congrats. All right, now let's move on to the final part of this summit, our Q&A with our experts. So if I can have our doctors join us on stage so we can answer some of your questions. Oh, and just a reminder, I said it earlier, for those that have received the Echo, that Alexa, it's amazing. It's if you want to put like reminders, you can have them help you with your reminders. You need to take your medications, exercise. Water, drink water. Okay, guys, let's see some of the questions that we got. There was great participation. Let me start here. Okay. The first question I just have here, they're asking about the importance of B12.
So B12 is very important for the neurological system, but having excess of B12 is not going to do much either. You're just wasting your money. So being deficient It's important to check for that because it can cause memory problems, it can cause issues with balance and neuropathy. However, having excess of B12 is not going to harm you, you're just going to urinate it. So check the levels, and yes, it's important it's a vitamin that has important use in neurology.
Perfect. Do you guys want to elaborate about the vivid dreams? Can you elaborate more?
Yes, so the vivid dreams, the name is REM, rapid eye movement, sleep behavior disorder, okay, REM behavior disorder. So some people might have a little bit of chit chat when they're, when they're sleeping, talking a little bit, and so those things don't count, right? It has to be something a little bit more pronounced, if you can say it. And it's typically, for some reason, people with Parkinson's disease tends to have vivid dreams, and those dreams tends to be argumentative. It doesn't have to be technically a fight. It can be an argument about the price of nuts and bolts at the hardware store, right? You want $1 for that? It should be 25 cents, right? So these kind of things, or we're playing basketball, and there might be a little bit of an argument about whether the play was good or not, right? So, but with this, there's activity. So there's some punching, there's some kicking that will be associated with this. And this is probably one of the main reasons. Some of you that are my patients, you probably heard me asking you, do you guys sleep in the same room, right? Because I'm trying to get into this, trying to get a little bit of this information. And many times the answer is, well, he's been kicking and fighting me and trashing. He didn't let me sleep, so I went to move to the other room. So that is one of those first symptoms. And some people believe that it could begin even 20 years, up to that point before a person comes to the clinic with the symptoms of Parkinson's disease. So it seems that Parkinson's is a long process, right? And the brain is doing a lot of adjustments to make sure that the symptoms are well controlled until it cannot do it anymore. And that could take 10, 15 years, which is when people show up.
Really quickly, and the difference between that and hallucinations is very important, okay? It's a common situation that we experience at the clinic, and most of the people and patients that would think that are hallucinations are referring to the vivid dreams, and the treatment is different.
This other question, they're referring about people that live here in Florida. It says, can you please discuss the importance of sunscreen, staying out of the sun, and increased risk of melanoma as it relates to Parkinson's disease?
So for some reason, there is a high risk of developing melanoma in people with Parkinson's disease. And there has always been a question whether the medicines that we use to treat Parkinson's might actually contribute to this. And, a lot of these reports actually come from up north. So, in Minnesota, the Mayo Clinic has always been very good at looking into these kind of things. And obviously, that's more of a fair skin population, high risk of developing skin cancer and melanomas and so on. But there seems to be some sort of relationship between high risk of melanoma in people with Parkinson's disease. So obviously, I believe that sunlight is important. It helps you get some vitamin D, and it's a phenomenal antidepressant at the same time. But too much of it can be an issue in the Parkinson's disease population, so just use moderation. Now, to the second part of the question, which is what kind of sunscreens to use, everybody has a different opinion. To me, an SPF 15 should be sufficient. If you can find something that is, it's good quality and doesn't have a lot of chemicals and all that, and, ideally it would be good to do some research about, what might be the right brand. I personally haven't thought about this, but I know some people that I can ask. So the next time you guys come to the clinic, I might have an answer about which brand probably they'll recommend.
Let me add something to this. But it's a good practice to go to the dermatologist if you have Parkinson's and be checked anyways, once a year at least, okay, just in case. And second, regarding the sunscreen, and now I'm going to talk more about cosmetic. I don't like how I look with the white sunscreen. So tinted sunscreens are out there, and they look very nice. It seems that it's like a foundation and everything. The important thing is to use it every day, but because even the light that we get from the windows can actually cause some damage. So you don't need to go to the to the beach or to the pool to wear the sunscreen. It should be a practice that all of us should be having.
Heather, I think this question might be for you. They're asking, what is the educational requirement for an elder care attorney certification? I guess if they're in the process of finding someone to help them.
So to be board certified in elder law means you're a specialist in elder law, and you have to go through a peer review and a judicial review, and then you have to take a one-day exam and pass the exam to be board certified. Any attorney in Florida that passes the bar can say they're an elder law attorney, and I would caution you when you look at, are they an elder law attorney, I would look at what other areas of law they practice. If they're also practicing criminal law, real estate law, PI work, they're probably not an elder law attorney. Elder law is extremely technical, and I would strongly recommend, you don't have to come to us, but there's other board certified elder law attorneys in Central Florida. Please go to a board certified elder law attorney. It's going to be well worth. Yes. You have to get recertified every 5 years. Mm-hmm.
Now, they did ask, how can they contact you? So if you want to.
So you can call us at 407-422-3017, or you can access us online at www.kirson, that's Kirson, Fuller, FULLER.com. And I have some business cards, so before I leave, talk to me and I'll give you my business card. Thank you.
I actually have a comment. So these things are things you have to do when you're good to do them, right? So don't wait until you are in need, because this just doesn't happen overnight in first place. Ideally, we want you to have, you should have decision-making capacity so you can, all these decisions are valid, depending on how deep they go, right? But it is very important that when you are, we need to have this stuff already up and running, at any time, because we just don't know what tomorrow brings, right? So.
And I'll make a comment to that. Can you hear me? Yes. Everyone says to me, I thought I would have more time. So I met with a child of an elder last week, and she said, I didn't ever get the durable power of attorney because I thought I would have more time. So please do it now. It's going to give you the ability to ensure that your wishes are honored and the people you want to make those decisions are making them. In Florida, if you don't have those documents in place, you could end up in a guardianship with a professional guardian or a child that you wouldn't want to be your guardian in charge. So these are simple ways to ensure that your wishes are honored. We can even exclude certain people from serving as your guardian if one were ever to occur, and sometimes that's important. We're seeing a lot of litigation happening with the baby boomers over money as elders are aging, where children are going to the court and asking for guardianship, and we want to avoid that.
Thank you. I think if we've learned anything about Parkinson's disease is that it does not discriminate. And I want to take a moment. Tony, you were the one that wrote this question, and he's basically asking, military and veteran bases, are there studies on military bases or risk for Parkinson?
So yes, and it have taken too long to get answers. Too long for our veterans that have been exposed to so many things to or to receive the care that they need. We're talking not only about the exposure to toxins in Vietnam or Gulf War or Camp Lejeune. We're talking about traumatic brain injury, PTSD, anxiety, and depression, all of which affect the patients. So unfortunately, I think that it takes a long time for the system to recognize this, and I'm sorry that you guys have to go through that, because you didn't sign for that, right? And we should be taking care of all of you who actually serve for us.
Yeah, that's it's a general feeling, not only from us in our clinic, but many other movement disorder specialists, we had these conversations in the meetings, like, like how many veterans we see, not only with Parkinson's disease, but other neurodegenerative disorders and cancer, diabetes, and even to the point that we're learning about firefighters and so on. It looks like this flame retardant and these kind of things, might have something to do, all this chemical exposure. So there seems to be something there, and just like what Dr. Bennett said, it just takes too long for this to happen.
And the exposure of toxins is one of the things, but the PTSD is another thing that is linked with memory problems as well, and even with risk of dementia. And as one of the veterans that I first saw when I moved here told me, while I was playing with Barbies, he was trained to what? To save us. So even going to training, I have patients that would say, well, but I was not deployed, doesn't matter. I'm sure that they train you, right? You went to boot camp, you were exposed to certain things. And all of that add up. So it's not only the toxins, but also PTSD, as I was saying, anxiety and depression, in between other things, that can cause some sequela on all of the ones that were exposed.
We have another question here from some of our caregivers. It says, how might we get or engage passive loved ones to help care for the person living with Parkinson's disease?
You know what, that is a major challenge, right? And you really have to be in the situation, understanding what is happening with the patient. At the same time, what is happening with the caregiver or care partner as well, right? Because they have their own challenges at the same time. So, these conversations need to be had inside the family nucleus, and trying to figure out what's going to be the best way, and trying to see what are the resources that are available. Are there any friends, family, people from church and all that might be able to help, because sometimes it may be very difficult for just one person to take over, taking care for somebody with a neurodegenerative disorder. So preparation is important. The early stages allows you to understand, what might happen in the future. And then if you happen to be one of those persons with Parkinson's disease that is more challenging that we see, then we have to make sure we're always asking the care partners, how are you doing? In the visit, sometimes the patient goes to the bathroom and I ask them, so tell me about you. What are you doing? How are you handling this, right? Do you need any help? Are the children involved? And trying to collect all this information. So, those things take a lot of time, and we try to do it because otherwise who's going to do it, right?
And that sense of community, right? Because like I mentioned earlier, now that my father's going through it with my uncle, when I go visit, I'll tell my father, I'm like, listen, go for a walk. I'll stay here. I'll help my uncle with his exercises. But it's just, I feel like it's also something that's very ingrained in our Latino culture. It's like, no, I got it. You don't have to help me, like I'm the dad, I'm the protector. This is my responsibility. He's my brother, and not allowing you to help them.
And a lot of the times, even, I don't know what the passive word mean, whoever wrote that, but for my understanding, passive could be somebody that is here and is not doing, it's not doing much. But it could be somebody also that is in another state, like a children that live in another state, and they're opinionate over the phone, but they don't know what's going on, right? And everything looks fine because you're not there seeing what's a day to day. And over the phone and in Zoom, we can pretend a lot of things, and we can come across like everything is fine, and the hysterical is the wife or the husband that is there on a day to day. So it's not the same, and listening to those people that live in another place and then come home and stay only for a few days, you can see they're like, I didn't even know what was going on. It's very hard to describe it, and sometimes even as you were mentioning, the care partners will actually say everything is okay 20 times before they acknowledge that there is something wrong. So another thing is, and point of interest, to talk to the care partners to see why it takes so long to say, I need help. And then where to get the help is the second thing, right? So it's a huge topic, and at the office we're very compromised with that. We do have caregiver support groups, and we listen to them talking between them and the stories. And this is something very real, because at the end of the day, each of us, and especially Parkinson's and Alzheimer's, we do need a care partner. We cannot do it by ourselves. At some point, somebody has to, is the one that is there even holding our hand and saying, everything is okay, I love you. So I don't think that this is a disease to be by ourselves, no matter what stage you are. So we have to take care of who's taking care of us.
And from a legal standpoint, I'll speak to that phenomenon. It's very common that one child would be in charge of the care or be the caregiver, quit their job, take care of mom and dad. The children that live out of state and fly in to go to Disney and pop in for a couple days, they sometimes go to court and file for guardianship because they decide she must be doing something wrong with the money. So you want to have all your documents in place to prevent that from happening. And as parents, we all hope that our children will get along, but it's not very common. So you want to protect yourself.
Thank you, Heather. I have a question here in Spanish that I would like for you guys to address it. ¿Es esta enfermedad hereditaria? ¿Puedo yo y mis hijos en un futuro tener Parkinson? This question, to translate it, this person is asking, is this hereditary? Can I give this disease to my children in the future?
So the question is about the genetics of Parkinson's disease. And some cases of Parkinson's disease can be in the genes. And typically those cases are patients developing the condition earlier in life. So, if you develop Parkinson's disease in your 40s, or very early 50s, or in your 30s, those cases very commonly are associated with some sort of gene mutation. Now, what we call the garden variety Parkinson's disease, right? The one that people start having symptoms between 55 and 60, and they're diagnosed between 60 and 65 and on. Typically, those cases, we consider them to be idiopathic. And idiopathic means something is causing it, but we haven't found the gene or anything else that explains what is going on. Now, having said that, we are actually doing a study right now looking for people with a particular genetic profile. And me, having done this for 20 plus years, I used to believe that the people that were going to show up for that study that we were going to see were people in the 40s or early 50s. And I have a lot of 60s and 70s coming positive for that mutation. So, it's a lesson for me that, look, some of these people that we thought they were going to be developing this condition in their 40s or early 50s actually are able to go further, and they're developing the condition a little bit later. So a lesson, we're testing now everybody that we diagnose right away, we offer the testing, let's put it that way. You don't have to get tested, because many times, we have people that come to the clinic, but their children doesn't want the parents to be tested because they don't want to have any issues knowing about a potential gene. But the truth is that now with these medications to try to slow down Parkinson's, it will make sense to look into this.
And this is very important, because genetics, I don't know if it's the word, but it freaks some people. They're like, are you doing what with my genes? Actually, even how the medication is going to work, we have been seeing that people that carry a certain gene may have hallucinations from certain medications that we prescribe, may have issues with cognition. And so the genetics is not only to know if I'm going to pass it, but it's also how you are going to react towards certain medications that we give. And if you don't mind, just one thing, because I think it's very important, is the importance of research. And the connotation of research in the Hispanics is that you're going to treat me as a guinea pig. And for the longest, it has been like that, because unfortunately, at some point, many years ago, some things were done, right, in my island, in Puerto Rico, and in other places. So from generations, it's very common to hear that my grandparent told me, or that my father told me, don't do that, because they're going to take advantage of you. Listen, if we don't participate in research, there's different reasons to participate in research. Let's start with that. It has to be voluntary, but at least listen to the idea before you even say no. Listen to what's going on and how you can benefit from it or how your children can benefit from it. And regarding my topic today about women in Parkinson's, it is very sad to tell you that we don't have data on women, that we're using that data on men and we're trying to put that in a women. And then we're seeing that the medication doesn't last long, that there's motor fluctuations, that there's all other things that are actually affected by the hormones, and we're just using the data of a man. So, and then the women's are underrepresented as well. If we don't step up in the plate, it's not even for us, for our children or whoever is coming, we're gonna even have the same discussion for years and years. So just listen to the idea before you make the decision. But consider it, because right now there's many rules, right, Dr. Rodriguez, and you can explain that a little bit more, and regulations. And I think that you know, that way of thinking at some point have to start to change.
We have 2 more questions here. There are more, and I might not be able to get to all of them, but if you guys want, after the event is over, you guys can try to grab the doctors and they can try to answer some of those questions for you. So these are the last 2 we have. What is the name of the medication that should be available in September?
Yeah, that medication, the generic name is going to be tavapadone. Now, it is not coming as a generic. It's going to have a brand name, and I came through the name, I just don't remember it. But we're hoping that September is going to be the timing that the drug is going to be available. Yes, tavapadone is the name of the compound.
And the last question we have here, when do you know if you need medication?
Oof, that's a great question. Everybody has a different opinion about that. So I'll tell you what I believe, and maybe Dr. Benes might tell you about hers. So, you know, when a person is diagnosed with Parkinson's disease, I believe that initial prescription should be saying exercise, diet, good sleep, socialization, keep your brain busy, you know, cognition, and meditation and mindfulness, right? And I like to let some people go home, you know, learn about the diagnosis, read more about it before they come back, and we can start having a conversation about medicines, right? One of the challenges that we see is that some people prefer not to begin medicine because they go to the internet and they read about these articles that are available, like, you know, the levodopa, the medicine is going to be toxic to your brain, and this and that, which is not true, right? You know, there were some opinions about that in the past, but we already have the data. The issue is the internet keeps holding that data for a long time, and people tend to gravitate, you know, to the information that they want to hear about. Like, if they don't want to start a medicine, they'll find the information that will support their decision. But the truth and the answer is, whenever you feel that Parkinson is affecting your quality of life, right, that's the time that you need to begin medicine. And I see some people struggling, really struggling. And here I am telling them, it is time for you to take a medicine. And they're like, no, I want to wait. And I believe it is, you know, I respect the decision, and I'll try to persuade them to begin the medication, but they really don't want to do it, and I think that is wrong. But I'll try to negotiate that with the patient. Now, when the day comes that we have a medicine that shows that it can help slow down the progression of Parkinson's, that needs to happen right away, right? You know, the first day that we suspect it, we need to begin this, because typically what those medicines are going to do is they're going to protect the brain cells that are still working. So in that case, it will make a difference. But as of today, and listen, I'm hoping, I think that we're knocking on the door to have some of these medicines come out very soon. But as of today, all the treatment that we have is symptomatic. It's just to make the symptoms better. So if you tell yourself, you know what, it would be nice that this tremor will not be here tomorrow morning, or wake up and feel like I'm able to go a little bit better or do the things that I want to do, that's the time to begin medicine.
And I agree with that. And I'm going to put the example of the headaches, because I think everybody relates to that one. I have a headache, and Dr. Rodriguez said, well, you can have 2 ibuprofen. And I said, no. And he's like, well, okay. And then the headache gets worse. And now I don't need 2 ibuprofen, I may need something stronger, right? So when is the right time to take it? When the headache bothers you, but don't wait until it's too much, because you might need something else. So I always remember Dr. Rodriguez, he trained me for movement disorder, and I always remember him saying the example with the house, right? That you try to keep the house up to date, and you'll check and make sure that it's painted and that everything is, or you wait longer until everything is falling apart, and it's gonna be harder as well. So if you're a surgeon and you have a little bit of a tremor, go and take the medicine so you can continue to be a surgeon. But if it is a tremor and it's not bothering you, but you're exercising, you need to be doing something else. I think that the message should be, besides the medicine and when to, the exercise and the rest of the things that we have been talking have to happen, and there's certain foods as well that would provide some amount of dopamine as well, natural, that some patients may start with those. There's some fava beans, there's tyrosine-rich food as well. There's different types of, different forms of dopamine that some patients start to use until the symptom is causing some issues with daily activities, such as brushing their teeth or buttoning their shirts. And in women, I have seen more stepping up the plate and saying, prescribe me something when they cannot wear mascara or do, which is the truth, right? For us, it's a feminine, so for everybody has a different reason, is what I'm saying. And we respect that. I would just say, don't wait until you're suffering. There is no need to get to that point either.
Excellent. Dr. Benes, Dr. Rodriguez, Heather, any last remarks?
Just get your planning done now.
Thank you so much. Thank you for all you do. What an amazing summit, so much information. I hope you guys all go home feeling empowered and inspired. It's been a pleasure.